Hey guys, am I audible and visible? If so, say me a hi. Hello students. Just a hi would do. So then I'll be starting the lecture as early as possible. A very hi Syed, hi Santosh. Thank you Santosh sir. Hi Nigam. So okay, so let's start today's discussion. I hope you guys gave the exam. I gave the test. How was it? Good, bad, ugly? I think the questions were pretty easy. At least just begin with, they were simple one-liners. Maybe a little bit of increase in the scenario-based questions toward the end of the exam. Hi, Sarah. Good evening. So we'll have a quick discussion of the questions, obviously the right answer, and also something related to the topic. So that after the class, I want you to go through the entire PDF. The PDF will be available for you in the app. Please go and have a look at it in the notes section inside the pathology. The lecture also will be available there. Quickly go through. We have the WhatsApp group there for all of you guys. Discuss there. Let's discuss any doubts you have. By today night, I want you to complete the section of pathology and concentrate on the next TND exam from tomorrow, right? Me and Saracha will be guiding you in the WhatsApp group, so we'll make sure that that also is taken care of, right? So let's start. So I want you guys to have a quick interactive session so that it will be useful for you, not just a lecture alone, right? So I want you guys to tell me the right answer, and I'll be asking questions with respect to discussion as well. That also I want you to answer, right? Kya is the answer? Cell swelling is primary due to accumulation of which of the following? A, B, C, or D. Just comment A, B, C, and D. That should be enough. I want you guys to comment. Okay, Sarah, Syed, B, rest of them. There are more than 10 plus people who's live. I want everyone to comment. So let's make it more interactive. Okay, B, Akhil, Upendran, B, right? Perfect. It's a very simple question, right? So I wanted to start the class as well as the test with a very simple question. So it's much comfortable for you to get into the groove, right? Okay, Krishna's opted for A. Krishna, A is not the right answer. The answer is B, right? Cell swelling, right? This is the first microscopic sign of cell injury. Please do remember that. Can anyone tell me cell swelling, is it a sign of reversible cell injury or an irreversible cell injury? It obviously is the first sign of reversible cell injury, right? It's simple first sign of reversible cell injury or a reversible cellular damage, right? So let's keep it interactive. Like I said, the moment the cell kind of loses its energy or an blood or a supply or oxygen, right? That's ischemia, right? The most common cause of cell injury is by default ischemia or infarction, right? So the moment it goes, there'll be reduction in the ATP formation, ATP generation, right? So once the ATP reduces, which pump will stop pumping, functioning? The one important pump which always confuses, you must have been reading from first year of physiology, right? What pump is that? We have the sodium, potassium, ATPase, right? So this is the pump which is a ATPase, right? It's ATP dependent. So if ATP is not there, this pump will stop functioning. It will not work. So if the sodium potassium ATP is not working, what will eventually happen? Your ionic imbalance will be there. This is going to attract more and more water. Okay? It's attract more and more water into the cell, which results in the simple cell swelling. That's all, right? I want you guys to answer for this question at least, right? Perfect, Usman. Answer for this question alone. Can I say that sodium potassium ATPase is there throughout the body, or it's only present in few cells in the body? What do you guys think? Because a very important thing on how to correlate and learn. Integration is very, very important, right? That's what the entire world is talking about, integrated studies. It is present in every cell in the body. Am I right? Right, throughout. Perfect, Upendran, right? It is present throughout the body. So can I say, if it's my brain parenchyma, if the ischemia happens, microscopic finding will be same cell injury, be it brain, be it heart, be it liver, be it kidney, will it be the same? Yes or no? Just yes or no should be enough for me. So if you can say yes or no, I can extrapolate to next 4-5 MCQs which came in your FMGE exam. Yes? Perfect, right? So cell swelling is same, that's all. It's the sign of reversible cell injury, right? Perfect. Now, let's extrapolate the cell swelling into brain. In brain, no, we call it spongiform degeneration or a spongiform change. The change is little bit spongiform, right? If you remember, there's a disease called as Prion's disease. The entire disease name is spongiform degeneration. It started from the appearance, that's all, right? The same thing happens in your Liver as well, right? In liver, we used to call them a ballooning degeneration, right? That's one more question. Now, I'm going to ask you a simple question. Can I say hepatitis can cause cell injury? Yes, no, maybe. Akhil, Upendra and Usman. Hepatitis can cause cell injury? Obviously, right? So the microscopic finding of hepatitis virus is ballooning degeneration. The same cell damage. It's not causing ischemia, it's causing some other damage. But it's same cell injury microscopically, right? That's all, right? In kidney, that's also an MCQ. In kidney, I call it vacuolar degeneration or vacuolar change. That's all. In an acute renal failure, acute tubular necrosis, you see vacuolar change. It is not different, it's the same because cell is the same, right? I want you to understand pathology like this, so revision becomes easy. I don't want you to go and write, okay, brain spongiform degeneration, liver balloon degeneration. It's same cell swelling, the name is different, that's all. It is seen in case of an hepatitis. I'm just giving an example of hepatitis because hepatitis is a PYQ. It can be seen in any liver damage, hemochromatosis, Wilson's, anything, but hepatitis came in an exam, right? This is acute kidney injury called as AKI or an acute tubular necrosis. ATN stands for acute tubular necrosis. Fine. If Santosh sir is still around, definitely must have taught you this about your pre-renal AKI, right? Pre-renal failure. One of the important causes of acute tubular necrosis. Same change, right? Here, any brain parenchyma, same change. It's the same cell swelling. We can extrapolate into multiple aspects. Fine. Perfect. We'll be reading pathology like this. Link general pathology to every concept of hematology or systemic pathology. So it's very, very, very simple, right? Next question. I want you guys to answer. Again, it's a very simple question. Very, very simple question. The hallmark of irreversible cell injury. What's the answer? Sarah, Akhil, Upendra, Usman, Krishna, Ashutosh, everyone, I want you to comment. A, B, C, D. Doesn't matter if you're wrong. Everyone is going for C, plasma membrane rupture, perfect. I'll change the question a little bit differently, right? Hallmark of apoptosis. Is apoptosis also same? It's also an irreversible cell injury, right? What do you guys think is the hallmark of apoptosis? Will the answer change or will it be the same? Hallmark of apoptosis. What will be the answer if it's a hallmark of apoptosis? Krishna has gone for B now. Can anyone answer for hallmark of apoptosis? If the question is hallmark of apoptosis, the answer is option D, right? So this will be the answer if my question is coming as necrosis or generally if I'm asking irreversible cell injury, because in apoptosis you will not have a cell membrane damage, right? If it's apoptosis, it's going to be this. See, both are irreversible cell damage, both necrosis as well as apoptosis irreversible, but microscopically it will differ a little bit, right? So I'm sure everyone knows this, right? Everyone knows that in apoptosis I don't have a cell membrane damage, right? So let's see. Necrosis is loss of cell membrane. Apoptosis is just condensation of the chromatin or chromatin clumping, the way you want to call it, right? This is very important. Let's take this and take it forward, right? Apoptosis. Okay. In apoptosis, tell me the cell membrane will be intact, right? I'm going to ask you leading questions. Ready for the answers? You guys, you should be ready, right? Cell membrane will be intact. Now tell me, if cell membrane is intact, will the intracellular contents come outside? Yes, no? Just yes or no. Cell membrane is intact, which means what will happen to the intracellular contents? Will they come outside? Will they leak outside? No. Intracellular contents will leak? No. Will not leak. Okay? This is very, very important. If it doesn't leak, okay, my cell is there, it is dead, no noise. When there's no noise, will inflammation be present? Will there be inflammation? Yes, no. You need not memorize anything. It's a direct logical answer. No, there'll be no inflammation. That's also very, very classical. If there is no inflammation, will the patient come to the doctor? This is not for MCQ. This is for our understanding. There's no inflammation. Cell is dying. Will the patient come to a doctor? No. Easy to diagnose, difficult to diagnose. Because of this, it's actually a bit difficult to diagnose. If a disease is by apoptosis, it's difficult to diagnose. That's why Parkinson's is difficult to diagnose. It presents very late because neurons die by apoptosis. Mutation, cells die. Cancer, late diagnosis because it's very, very difficult to diagnose, right? Apoptosis is very difficult to diagnose. Now, let's take necrosis. Fine. Once a question came in a NEET PG exam, I'll give the premise of the question, then we'll talk about the question. Fine. If you have to look for LFT, liver function test, what are the enzymes comes to your mind? Anyone? Any one enzyme? There are lots of enzymes which comes in LFT. Any one enzyme? AST, ALT, GGT, all these are enzymes of liver function test, right? Okay. In hepatitis, the elevation of the liver function test enzyme is due to which of the following? Same option. The same question in hepatitis, elevation of AST or ALT or GGT, whatever you want to call, is due to which of the following? Cell swelling, ribosomal, plasma membrane rupture, chromatin clumping. Is due to same plasma membrane rupture, right? Because in necrosis there's a plasma membrane rupture, there'll be intracellular contents will leak. Fine. Okay. See, this was a PYQ, that's all. But I can change it in any way. I'll give an history of myocardial infarction. What is the reason of troponin T elevation? Same reason. I'll give a history of crush injury, muscle damage. What's the reason for creatine kinase elevation? The same thing, right? Because of this, I can use all the enzymes for diagnosis. What's the enzyme used for pancreatitis? Anyone? It's the same thing, right? Be it an troponin 3, troponin I for MI, be it your amylase for your pancreatitis, lipase for your pancreatitis, all of them is due to this, right? Is due to necrosis only, fine? Is due to cell membrane damage, fine? Perfect. Now, let's quickly revise what are the types of necrosis. Few important pointers. I've kept multiple blank places in the next slide. I want you guys to fill it up, fine? Okay, ready? Coagulated necrosis. It's due to infarct of which of the following? It's obviously infarct of, everyone knows that liquefactive necrosis is infarct of brain parenchyma, right? Coagulated necrosis, infarct of every solid organ, right? Every solid organ's infarct will be coagulated necrosis except one infarct, which is brain's infarct. Very simple, perfect. Which is the most common subtype of necrosis? No doubt in that. Whatever you read first will be the most common, right? Okay. See, liquefactive necrosis, there are two other causes of liquefactive necrosis, right? One, it is in case of acute pancreatitis. Acute pancreatitis, in the substance of pancreas, you'll have liquefactive necrosis. In peripancreatic fat or omentum, you'll have fat necrosis. Please put a star mark here. Read the question properly. Case of acute pancreatitis, what I'm talking about? Omentum, fat necrosis. Pancreas, liquefactive necrosis. Fine. In case of any suppurative infection, what is suppuration's meaning? Suppuration ka matlab, it is full of WBCs, neutrophils. That is suppuration. Your wet gangrene is suppuration. Fine. Any pus, abscess cavity is suppuration. Fine. That's what it is. Fine. Perfect. Great. Rahul, mechanism of action of coagulated necrosis. Rahul has started the next one. He's saying it's denaturation of protein. How many of you say Rahul is right? It is denaturation of protein. It's absolutely right. Right? It's denaturation of protein. Right? Now, let's understand the mechanism of action of your liquefactive necrosis from this answer. What do you think is the mechanism of action of pancreatitis? The answer is just in the comment box. It's the lipase, right? So here, it is not protein degradation. It is enzymes activation, right? Enzyme activation will result in liquefactive necrosis. It's not proteins change. It's enzyme activation, right? It's very important to know that in coagulated necrosis, the architecture will be maintained. In liquefactive necrosis, liquefies. It's become a liquid. I cannot maintain an architecture, right? I'll show you what this means with an image, right? This, I want help from you guys. Whoever is online, I want you to tell what this structure is. This came once in an EPG exam. This structure was asked, and they asked, what is this? What is the structure? Normal histological structure. If you want, I'll erase the line. What is the structure? This one. That's a simple normal glomerulus, right? Perfect. That's a simple normal glomerulus, right? Amazing. So what are these structure? Can anyone say what these are? If that is glomerulus, I'm sure you'll be able to say what these are. What are these? What are these? What are these? That's a simple, perfect tubules, right? You guys were able to identify tubules, right? The best part, no? I'll zoom this tubule. This tubule is dead. It is not alive because pink color. Pycnosis, karyorrhexis, karyolysis, nucleus gone. Every tubule here is dead. Even if it is dead, you can say it is tubule because architecture is maintained. This is what architecture maintained mean. It's dead structure, but still I'll be able to identify, you are able to identify it's a tubule, right? That's architecture maintained. And the most important thing, microscopy, necrosis will be pink in color. That's all. Every necrosis in microscopy has to be and will be pink in color only. Fine? Perfect. Now let's go to the next one. Just to finish off necrosis, one cause. The common one which comes in exam, caseous. Caseous, till you die, it's only one guy. TB, unless otherwise proven, tuberculosis only. We do have some condition like histoplasmosis, coccidiomycosis, but fine. It's not okay. It's tuberculosis only. TB, one and only TB. That's all right. Okay. This is my favorite thing. OID. What's OID? OID ka matlab? OID means like. That's all. OID means like. Fibrinoid necrosis means fibrin-like necrosis. Right? Very, very simple. Mohammed, you are amazing. But I don't want you to read only SLE, PAN, or like Syed said, PAN and rheumatoid arthritis, right? That is the problem. Memorizing facts is a problem. Oid means like. That's all. Colloid, collagen-like. Fine. Amyloid, amylin-like. Lymphoid, lymphocyte-like. Myeloid, myelocyte-like. Leukemoid, leukemia-like. Fibrinoid, fibrin-like. Where do you see fibrin? Just tell yes or no. Will you see fibrin after a blood clot? Yes or no? Will you see fibrin after a blood clot? Obviously, right? When will you have blood clot? Which structure damage you'll have blood clot? Everything, whatever you memorize will be gone. Which structure damage you'll have blood clot? Blood vessel damage, that's all. So fibrinoid necrosis is equivalent to vessel wall necrosis, right? That's it. Now let's take all the examples. PAN, vasculitis, SLE, vasculitis, malignant hypertension, rupture of the vessel, rheumatic carditis. Heart is the biggest vessel. If the vessel wall undergoes damage, it's fibrinoid necrosis. It's there in the name. My only reason to learn concepts is, let's say I change the question from PAN to Kawasaki disease. Will Kawasaki have fibrinoid necrosis? Yes or no? Absolutely. It's a vasculitis. PAN was a PYQ. It is not a previous year topic. It's a previous year question, right? It will be any vasculitis. Fine. Any vasculitis will have fibrinoid necrosis. And also, obviously, your rheumatic heart disease, because remember, heart is considered to be the biggest vessel, right? It's the biggest vessel, then comes the aorta, right? Any vasculitis, any rheumatic heart damage, you will have that, right? Sorry. Okay. Perfect. Right. Next, fat necrosis. There are two types of fat necrosis. Fine. One is your trauma-induced fat necrosis. The other is enzymatic fat necrosis. Fine. Trauma-induced fat necrosis. Now it's simple. Any organ which is rich in fat. Breast has a trauma fat necrosis. Gluteus has a trauma fat necrosis. Right. Any rich in organ, simple trauma-induced necrosis. Enzymatic is your acute pancreatitis. So in acute pancreatitis, what happens is the amylase and lipase you said will be released. So that will cause omental necrosis, right? That is definitely your fat necrosis. Simple, done. I'll try to relate this trauma-induced necrosis. Let's try to relate pharmacology. I'm sure Suraj sir must have told this, right? Can anyone tell me one side effect of insulin injection? Nothing needs to be memorized in medicine. One side effect of insulin injection. Insulin. Have you heard about this side effect? Lipodystrophy. Have you heard about this? They must have told for sure, right? Perfect, Sarah. Lipodystrophy. I give insulin here. Fat. Repeated trauma. Fat undergoes necrosis. Lipose fat. Dis is abnormal. Atrophy is destruction. Lipodystrophy of insulin. So now tell me, the problem here is insulin or injection? The problem here is injection, not insulin. If I keep on giving tetanus injection here daily also, it will happen. The problem is trauma. repeated trauma has a problem. Insulin is the mode of delivery. That's it, right? Perfect. Now let's go to the next one. Learn medicine for the love of medicine. Exams you will definitely clear, right? What's the answer? Simple one, A, B, C, D. Everyone will get involved. It's okay if you're wrong. This live comment no will disappear. It's okay if you're wrong, or if you feel you're okay, someone will laugh at me, delete the comment after that. It's okay, but I want everyone to answer this. Which enzyme is released from the damaged mitochondria activates apoptosis? B, right? Everyone should answer like Rahul, right? B, right? You're right. You're right. Cytochrome C, right? Perfect. If you have written A, because caspase no attracts. Once there is a question of apoptosis, automatically caspase attracts and you go there, right? The question is different. It's released from mitochondria. From the damaged mitochondria, cytochrome comes outside and activates everything, right? Let's quickly look at apoptosis. And before that, now just little bit information about the genes, right? So these genes are important for us to understand. There are three groups of genes: anti, pro, and sensors. Okay, anti-apoptosis. If a gene is anti-apoptotic, just you tell me what will be the lifespan of the cell. Longer lifespan, shorter lifespan. It is anti-apoptosis. It's going to stop apoptosis. It's a longer life, right? Obviously, right? This kind of, I won't say mnemonic, a trick to remember, that's all. Whatever has L in its name is longer life. BCL2, BCLXL, MCL1, right? It's L, it's L, it's L, it's L. The only exception is BCLXS, right? That's why I put that in red color. It's an exception. It's not important, but it's an exception. It might confuse, fine? Everyone will know backs and back. Those are pro-apoptotic genes, right? Sensors of cell stress, actually they are pro-apoptotic. In principle, they promote apoptosis, but I don't classify them as pro-apoptotic. It's BIM, BID, BAT, Puma, Noxa, fine? So what happens now? In a normal mitochondria, cytochrome C, what is the normal cytochrome C's function? Biochemistry में have read? याद है? Normal cytochrome C's function? Electron transport chain, you have lots of cytochromes, you know. So normally cytochrome C will be inside. Why inside? Because normally I'll have BCL2, है ना? BCL2 will stop the entry. So agar when you have a mutation, any mutation is one of the important trigger. This will increase your BIM, BID, BAD group, that group, right? And it will destroy your BCL2, and it will, this BIM, BID, BAD group, na, that will activate your backs and back. See, backs and back is pro-apoptotic, actually the exact opposite na, of your BCL2, right? It will activate. So this will push your cytochrome C into cytoplasm. It goes to cytoplasm, it binds to one more protein called as APAF, apoptosis activating factor, okay, and it will produce one thing which is apoptosome. Fine. And apoptosome function is it activates your caspase. What's the caspase number? This number is important. I'll enlist the other caspase number also. Caspase, this is intrinsic pathway, right? Caspase 9. That's a pro caspase 9 to active caspase 9. Right? It's active caspase 9. It will be converted, right? So this is intrinsic. So in extrinsic pathway of apoptosis, we have caspase 8 and caspase 10, and both will join and come to the execution phase. In the execution phase, we have caspase 3 and caspase 6. These are the terminal caspases. Apoptosis is caspase dependent cell death, right? This is in short about apoptosis. Everything required for apoptosis, intrinsic, extrinsic, common is there. Okay, fine. Now, just a single query, one question, answer if you know, that will relate to the next slide. In apoptosis, what is the nuclear degrading enzyme called as? Is it nuclease or endonuclease? Just that alone. Come on, everyone. In apoptosis, what's a nuclear degrading enzyme? Nuclease or endonuclease? Just two options, no? Anyway, you have 50% right answer. Okay, Upendran has gone with nuclease. Everyone else. Okay, Sarah has gone with endonuclease. Come on. It is endonuclease, right? Do remember that. It's always important for me to remember that in apoptosis, along with caspase in execution, I have an enzyme called as endonuclease, not nuclease. See, nuclease is seen in necrosis. Okay, here is endonuclease. What is the difference? The difference is the function. If you remember, biochemistry may have read enzymes called as restriction endonuclease. Yes, you remember? You do, right? A restriction endonuclease destroys a DNA anywhere or only in particular sites. What do you think? They destroy the DNA only in particular sites. Can anyone say what sites? They are called as palindromic sequences, right? Perfect. Endonucleases, restriction endonuclease. They cut the DNA only at particular sites. They don't cut anywhere. So now tell me, in apoptosis, DNA will be digested or DNA will be cut? DNA will be cut. So I do an electrophoresis. So which will be apoptosis? Let's mark 1. Okay. Let's mark 1 and 2. Which will be apoptosis? DNA will be cut or lysed? Here it will be cut because it's endonuclease, restriction endonuclease. It has to be cut. See, if I cut this pencil, tiny parts, I need not memorize. Step ladder, because of DNA endonuclease activity, because of that endonuclease activity, you have fragments of DNA, not lysed DNA. It's fragments of DNA, right? Perfect. And here, in necrosis, it's not endonuclease, it's nuclease. It lyses everything. It makes a smear out of it, right? This is your DNA nuclease activity. And this is obviously a PAQ. You must have known this for sure. This is your smearing pattern seen in case of necrosis, right? Perfect. If you know normal, you can easily relate to this. As simple as that, right? Next question. Very simple question, next one. Answer. Here I want everyone to answer. Everyone should answer this. No, it's very simple. These are like feel-good questions, right? Has to be alcohol abuse, right? Now, I'll change this question. What will be the right answer? If I change, what will be the right answer? NAFLD or alcohol? NAFLD stands for non-alcoholic fatty liver disease. The answer has to be this guy, right? So please remember, non-alcoholic fatty liver disease is more common than alcohol-induced fatty liver, right? It has changed a lot. Incidence has changed because everyone here will eat burger, pizza, vada pav, everything, right? Not everyone here will drink daily. That's why junk food is a cause. Irregular intake is a cause, so that is definitely much more common than alcohol. So the disease also is very common, right? So the purpose of this question is not to discuss about alcoholic liver disease. Purpose is to discuss about stains, right? So now we have few named things here, like we have pediatric PM, right, Usman? So a few named things here like fat, hemostatin, copper, calcium, melanin, glycogen. The first is what will be the color in microscopy. The second is what are the stains used for this, right? You will fill the first one, I will fill the second one, right? Can anyone tell what will be the color of fat in microscopy? Fat will appear, perfect. It will appear clear in microscopy because fat will be washed away during processing. When I process tissue, it will be washed away, fine? Okay, great, Nazar, all the variables do well. It will be washed away completely, right? So once it's washed away, it will be clear, right? One more question. The stain for fat is your Sudan black. Both can be used. It's Sudan black can be used and oil red O also can be used. Very simple stain, right? And one question came, if fat is washed away in the microscopy, I can't do the stain, right? I can't do the stain because it's empty. It's washed away. So इसलिए the fixative for Sudan black is your glutaraldehyde. I cannot do it in a formalin fixed tissue. That's important. To do a fat stain, we need glutaraldehyde because glutaraldehyde will not wash away fat. Fat will be washed with alcohol or formalin, not with glutaraldehyde. Remember them, right? So can anyone tell me what will be the color of hemostatin microscopy? You have to tell the microscopic color, right? I'm not leaving you guys. Open up. It's fine. If you make a mistake, it's fine. Hemostatin is iron, no? Kya hai color of rust? You must have seen rust and iron naked eye, no? What's the color? Simple, the same color here. Right? It's brown in color. Simple brown color, na? you must have seen for sure, brownish in color, right? Why blue? See, you have seen iron? You must have seen iron. Rust, na? Iron is rust. Rust is brown in color. Have you seen copper in naked eye? Yes, copper wire, copper bottom vessel, copper water bottle, copper color. That also is brown in color, right? What is a melanin's color? Melanin ka color? Melanin's color is not black. Melanin ka color is brown in color. Please remember this. When melanin is very condensed, it looks black in color. Right? We are brown people. That's what the Americans and Europeans called us. No, we are brown. When it's very dark, very condensed, it will definitely become black. Right? It's also brown in color. Now my problem is I cannot differentiate these three in microscopy because all three are brown in color. So I need a stain. What's the stain for hemosiderin? Hemos is nothing but iron key deposit. Na? Iron stain? Yes, Shahjahan. Any concerns? Iron stain is pearls. Pearl stain, yeah. Pearls, Prussian blue stain. Fine. Both are same. Pearl stain or pearls Prussian blue. Fine. Copper stain. Copper stain, there are many copper stain. Na? Copper stain is your rhodonine is a copper stain. Na? Rubionic acid is a copper stain. No? One more thing is orcine. Actually, real life mein orcine is used much more commonly than rubionic acid and rhodonine, right? Rhodonine and rubionic acid is for MCQs. We don't use rhodonine or rubionic acid in the lab. We use orcine in the lab, fine? Okay. What's the stain for melanin? Melanin stain is, everyone knows, na? Masson Fontana. How many of you before this class itself knows that melanin stain is Masson Fontana? Almost everyone, no na? Akhil, I'll come to 𝐌𝐞𝐝𝐄𝐝 very soon. It's calcium, I missed that. I'll come to it soon. Everyone knows it's Masson Fontana, right? So now, last year, I think NEET PG or FMGE, I'm not sure which exam, they changed this question a little bit. Everyone knows Masson Fontana's melanin stain. So how they changed was, what will be the stain for pigmented fungi? Pigment fungi, what will you see? Same melanin. In options, there is no fungal stain present at all. They gave Congo red, they gave pearl stain, they gave 𝐻𝐶𝐝, and the last one was Masson Fontana. Masson Fontana is positive in melanin. Also right, Masson Fontana is also positive in pigmented fungi. It's pigment, right? It's pigment. So wherever it is, it will be positive. Schmorell stain also is good. Again, Syed, we don't use Schmorell much, but yes, Schmorell also is a stain for melanin, right? So melanin or pigmented fungi, you will have Masson Fontana positivity. If they change the question, think for 5 seconds, you'll know the answer, right? Okay. Calcium, I am sure every case knows mnemonic, right? Everywhere, entire pathology department, the first thing they talk about is this KAL, right? So obviously it is 𝐻𝐶𝐝, 𝐻𝐞𝐝, and alizarin red. Alizarin red is best stain, but alizarin red is sort of expensive. That's why they don't use it much. Fine. What's the color of calcium in microscopy? It's simple bluish in color. Glycogen na, can be light pink or clear. Right? It has both the color. I'll give you a simple explanation to understand. Can anyone help me in understanding what is glycogen? Science should excite you. It will excite you. We have to correlate with real life, that's all. What is glycogen? Glycogen is sugar's storage form. Yes, no, maybe. Yes, glucose is stored as glycogen. Yes, perfect, Mohammed. Now, sugar, na, if you see normal sugar, it is a little bit opaque, white in color. Na? It's opaque structure. Have you seen, I'm not sure what's the name of that in your local language. Have you seen misri? The condensed form of sugar which they give in marriages and which they have in mouth refreshener. Have you seen that? That is condensed form of sugar. It becomes a little bit clear. That is in real life. Microscopy also same. If glycogen is less amount, it will be pink in color. If glycogen is condensed more in amount, it becomes clear in color. That's how sugar behaves. Not glycogen, it's sugar. Real life, the same thing it will work here, right? Sugar has the same appearance. Here also the same appearance. That's all, right? So now, why I said this is, don't always look for this question, this in the question. Glycogen storage disease may, there's a classical finding in liver, that is plant cell-like appearance, right? Plant cell generally is clear, fine. So plant cell appearance, I am 100% okay with it. Not always. Can also be pink in color. Remember that, fine. Okay, now let's come to our question. What is glycogen stain? Glycogen stain. Glycogen stain is perfect. It is PAS. One more thing, which is diastase sensitive. This is very, very important. PAS positive and diastase sensitive. Yes, Sarah, PAS is positive for neutral mucin also. Right? It's PAS positive and diastase sensitive. This is very important. Its meaning is simple. Diastase is an saccharidase. It will digest glycogen, that's all, or digest sugar, right? See, all these are facts. These are not questions, these are facts. If you know this, we can easily create a scenario-based question. Fine? How scenario-based questions are created? Taking multiple facts and merging it, okay? Now, 𝐌𝐞𝐝 disease is a glycogen storage disorder, right? You will see it in liver biopsy. Liver biopsy may, if you see PAS positivity, I'll think of 𝐌𝐞𝐝 disease. Fine. I'll change the question. In heart biopsy, I have pink color accumulation, and that is positive for PAS, diastase sensitive. What disease is that? Heart biopsy. There is one glycogen storage disease in the table which involves heart. Kaun si disease? You know that for sure. Starts with P. Answer. If you're wrong, that's all. Don't worry. Pompey's. Amazing, Mohammed. That's how I create new questions. It is not new disease. It's a new question. Now let's change. Play around with it. Right? Jay, October 6th May. Muscle biopsy has glycogen positivity, PAS positivity. So that is sensitive. Which disease? Which is muscle phosphorylase defect? McArdle's. I can change the question. It's the same fact. Every year, I cannot change glycogen. I cannot say glycogen storage disorder. But one thing, I can create multiple questions. I can create questions with this Pearl's Precision Blue. Liver, damage, deposit, hemochromatosis, hemosiderosis. Simple. Copper, beat the eye, basal ganglia, Wilson's disease. We'll create scenario-based question with these facts, right? Perfect. Done. Next question. Answer. It's just a very simple application of what we already know. A, B, C, or D. Okay. Perfect. Sarah, why C? Upendran, why C? We'll come to it soon. Fine. The question is 55-year alcoholic. Liver biopsy shows a large clear vacuole. It's clear. Now, apoptosis will never be clear, right? So it is not C, right? Necrosis will not have a cell. It's destroyed completely. It'll be completely pink, right? And that displays the nucleus peripherally. So these both options could be right. A, I accept. But C and D should not be the answer. See, these are blunders. Don't do that. Fine. A is also clear. Hydropic change is water clear. Fatty change is obviously fat is clear, right? Now the question clearly says this. There's a vacuole. So let's assume this is normal hepatocyte. Fine. And it's having a vacuole inside the hepatocyte, which is pushing the nucleus towards the corner. This is what the question says, right? If it's water, will it push the nucleus to the corner or it will just swell the cell? Hydropic degeneration will only cause swelling. It will swell. It will be clear. But nucleus will always be in the center. In ballooning degeneration, nucleus will be in the center. It will not be pushed to the corner. If it's pushed to the corner, this is Fats vacuole. Fine. It's a simple Fats vacuole. Very, very important. Remember it, right? Anywhere, if it's going to the corner, something is accumulating inside, and in hepatocyte, with the help of alcohol history also, it's fats vacuum, right? One more finding in alcoholic liver disease. Let's understand that also. Fine. Ready for it? Alcohol is a toxin, right? Every toxin in the body can damage the cells. An alcohol's toxin, especially alcohol's toxin, is aldehyde. The compound acetaldehyde is actually the toxin in alcohol. Fine. This aldehyde destroys cytoskeletal protein. Okay? It destroys cytoskeletal protein inside the hepatocytes. Fine. Now let's assume this is normal hepatocytes. Cytoskeleton का मतलब body skeleton gives structure to my body, right? Cells, proteins give structure to the cells. Those are cytoskeletal proteins, right? This is how normal it be. Protein normally is pink in color. Because of the structure, it has an oval or polygonal shape. Fine. Now, it's been destroyed. When you destroy any protein in your life, it becomes dark or light. This is my first question to every second year student. You destroy a protein in your life, it will become dark or light. It always becomes dark because proteins precipitate, right? Omelette is protein. Precipitation becomes darker, becomes opaque, right? Now, the problem is it changes in shape because shape is gone, right? Second, it will become dark. It will become dark and thick. It's a precipitate now. Fine. There's one term in pathology. If it's pink and I don't know what it is made of, I use a term. The term is hyaline. So can anyone tell me what this is? Can anyone tell me what this is? If I don't know what it is made of, if it is pink in color, I call it hyaline. You must have read now hyaline membrane disease in lung. Pink color, that's all. Hyaline. Hyaline arteriosclerosis in blood vessel. Hyaline. And what is this? This is nothing but, you must have heard this for sure. You're not able to relate it, that's all. Have you heard about Mallory hyaline body? You must have, na? Alcoholic liver disease finding. You must have heard? Yes, no, maybe. Mallory hyaline body. You must have for sure, right? Simple. This is Mallory's hyaline. Mallory discovered. If Muhammad had discovered it, he could have called it Muhammad Aiden. Perfect, Upendran. That's my next question. Why did we change the name? Because Denk, na? Denk is also one more scientist. He said that it is not something. Okay, I'll come to tell you. Just give me a second. It's not something. Denk said that it is CK8 and CK18 destruction. So I know what it is destroying. So we removed hyaline and put Denk's name, Mallory Denk body. Right? Okay. Okay. Mohammed, if I have to talk in general about paracetamol toxicity and liver damage, most of the drug-induced hepatitis will have microvesicular steatosis. That is common in general. Fine. That's what we see in general with respect to anything like aspirin-induced Ray's syndrome, microvesicular steatosis. Little bit of variational zone damage can be there. So if it's an MCQ, I would want to know the options to tell the right answer. Fine. Okay. Fine. So these are just something about alcoholic liver disease. Okay. Just one more, then next go to the next question. Tell me, this is proteins destruction, no? Yes. Random question. Can hepatitis also cause cytoskeletal damage in the liver cell? Yes, no, maybe. Can. Possible, na? Acute hepatitis, it's a damage to the cell, it will. So is Mallory hyaline specific or non-specific? It is very non-specific, right? Mallory hyaline or Mallory Denk, whatever it is, na? It's a very, very non-specific finding because any disease which damages cytoskeleton of the hepatocytes will cause Mallory hyaline body. Fine? Perfect. Next one. Tell me the right answer. Sorry. Akhil has gone with A. Ischemic preconditioning. Mohammed has gone with B. B. Okay, we'll look at what is A also, Akhil, and then we'll look at the right answer as well, right? See, actually the question has the answer more or less. Acute MI undergoes reperfusion, shortly after there's a sudden increase in tissue injury mediated by reactive oxygen species? Fine. The answer is reperfusion induced damage. It's a simple case of reperfusion injury, right? I'll tell you what is ischemic preconditioning means, right? So now precondition is not dying. It's already conditioned slowly with ischemia, so it can withstand more and more and more oxygen loss, right? Ischemic preconditioning ka matlab it's simple. Here, the muscle can actually withstand more ischemic damage because slowly I'm conditioning. The easiest example to relate, let's assume it's an alcoholic. First time you drink, okay, one beer, you might get high. Fifth time you drink, one beer not even do anything to you. Preconditioning. My body gets used to it. So slowly when the oxygen level reduces, my muscle gets used to ischemia, right? That is ischemic preconditioning, that it won't die. Here it dies more. That's classical reperfusion injury, right? Next question. The question itself has the answer also. What is the reason for reperfusion injury? Anyone? This also came in a PYQ. What's the cause of reperfusion injury? The cause of reperfusion injury is the most common causes reactive oxygen species induced damage. Fine. That's the most common cause of reperfusion injury, right? What does reperfusion injury means is when I give blood supply, the tissue is dying more. Question should be why, If I give blood supply, the tissue should be saved. That's the idea, right? Now, let's take, there's a patient with stroke. Fine. You must have read medicine, na? One of the treatment is thrombolysis or percutaneous coronary angiogram for your heart and other things, right? So here, let's assume I am giving thrombolysis. Fine. I'll ask you a medicine question. You have to answer this question. Can anyone tell me within what time? There'll be one critical time, no? What's the time for thrombolysis in stroke? I don't know the right answer, but I'm sure you know the answer. Streptolysin. So streptokinase. 4 hours. Superb. Right? 4 hours. Right? I have to give between 4 to 4.5 hours. I don't know the right answer. Like I said, Dr. Santosh sir will tell the right answer exactly. Why 4 hours is the question. If I give less than 4 hours, reperfusion damage is lesser. Still the damage will be there, but the reperfusion damage will be less. Benefit will be more. I came up with a study. Lots of study has been done and say within 4 hours I reperfuse, within 4 hours I thrombolyze, it is good for the patient. Again, if I give beyond 4 hours, let's assuming 4 hours is the reperfusion time for stroke. 4.5, please go with Santosh sir. I am not going to be telling about that, right? Now, let's assume I give more than 4 hours. Now, there's a vessel, there's a thrombus, and this part of the tissue is, there's a part of the tissue which is dying. Okay, slowly dying. Okay, man, I'll have a look into it, man. Right? Slowly it's dying. Okay, you're saying the TND, I'll change it. Its answer is reperfusion injury. Fine. Now I'm thrombolizing. The moment you thrombolyze, you'll have fresh blood coming inside, right? So the fresh blood will have fresh reactive oxygen species. It'll have fresh reactive oxygen species, right? And this fresh blood, the problem is this dying tissue, what do you think will be the level of antioxidants in the dying tissue? Low, high. It's dying, slowly dying. Its level of antioxidants is very less. The enzymes, what you must have read, catalase, superoxide dismutase, glutathione peroxidase, all of them will be very, very less, right? Very less antioxidants since the tissue is dying, and fresh reactive oxygen species that will cause more death of cells, right? That is the reason we need to give within the stipulated time. Very, very important. If I thrombolize beyond that particular time, it will undoubtedly cause more damage. Fine. Okay, that's the answer for this. It's a reperfusion induced damage. Okay, done. Next question. Answer. Simple one. This is actually a useless question. I gave this question for only one thing, right? How many of you will accept that last time of FMG exam, if you have written, that you made at least 5-10 silly mistakes? Possible, na? Yes, no? I know the question, I know the answer, but still I marked wrong. Possible? Possible. Because we are always in a hurry. We don't read all except. We don't read for 4 last option, right? It must have cost you 5-10 marks. 5-10 marks. You must have cleared the FMG exam. This is for that. Because the moment you see vascular change, no, what will mind say? Go with vasodilatation, increase in vascular permeability. That's always there in the head. But this word is important. If you miss this word, you must have given the wrong option. Like I said, vasoconstriction is useless. Okay? Right? So vasoconstriction is a useless thing. It's transient. It's not useful at all. Right? So vasoconstriction is a very transient phenomenon. It has no role in inflammation. It's just a protective response. It's just a knee-jerk response, right? Simple real-life analogy. If someone comes to slap you, what will you do? Will you slap back first or you'll protect first? You'll protect first. That's a response. An organism came inside, my body is contracting. Then it knows, okay, it's a streptococcus only, let's kick back. Then comes your vasodilatation. Vasodilatation is very important, but it's very transient, has no role in inflammation, as the earliest change. Sequentially, that's the earliest change. The answer is vasoconstriction and not vasodilatation. But what's the hallmark? Hallmark is simple, right? Hallmark is by default your vasodilatation, VD for vasodilatation, and increase in your vascular permeability. That is the hallmark of acute inflammation, nothing else. Vasoconstriction has no role at all in the, but it's a first and the initial response. Fine. Let's quickly recap the steps of inflammation. Yes. Okay. I'll tell you the steps. You will tell me the molecules, because telling the steps is very easy, right? The first step, let's say it is vasodilatation. Fine. Who causes vasodilatation? It's the mediators. Histamine is one of the important guy to cause it. Fine. Because of vasodilatation, let's say this is the normal vessel, it is getting dilated. Will there be turbulence? It's not a normal flow. Normally they'll have streamlined flow. It'll become turbulent now, no? Become very turbulent. Because of the turbulence, what will happen to the heavy WBC will come to the corner. Can anyone tell me what is the name of this step? All the WBC, because of the turbulence, will settle down. That name is, it's a very superb name. Explains what is seen there. We call it margination. Right? Margination is due to vasodilatation, right? Krishna, it's not yet rolling, it is just settling, right? So we call it margination, right? It's a direct vascular phenomenon, and selectin molecule helps in margination. It doesn't play a major role, it helps a little bit, right? That's the first one. Vasodilatation and margination, right? After margination, like Krishna said, let's assume that there's a blood vessel. Fine. And our bacteria is here. Okay. And our endothelium has opened here. The door has opened here exactly so that I can exit and eat the bacteria. Now, all these cells are marginated here. What's the next step? I'm in the margin. What's the next step? Has to roll by default, right? So next step is it has to move here. Okay, it keeps on moving. At this point, it will stop. So the first step is rolling, right? So can anyone tell me what are the molecules involved in rolling? The molecules involved in rolling slowly rolls over the endothelium. Two molecules, just two molecules. Then it will stop exactly here because I have a gap there, right? So that is called as an adhesion. I am not going to tell the molecules. You only will tell the molecules, right? Okay, perfect. Selectin, amazing. Another molecule. I have two molecules. Everything they'll see, because something to act, there has to be a ligand, there has to be a receptor. Two things should be there always. One thing will not help. Selectin is one. Perfect. I'm not denying. One more. There's a molecule called a selectin By, you're right, you're absolutely right. One more. Yes, E-selectin, P-selectin, L-selectin, fine. All are selectin. They do only one part. Who is the other part? Other part is in the WBC. You must remember this, no? Cialyl, Lewis, XK receptor, right? That is binding, right? So Cialyl Lewis X is on the WBC. Selectin is on the endothelium. Fine. So endothelium has selectin. WBC goes and binds, slowly rolls. Okay. At some point of time, it will adhere. What are the molecules required in the second step of adhesion? Two molecules again. I always need two molecules. One I have. One I'm sure you know. I will tell that. You tell the other one. One is integrin. That's the easiest one, no? Integrin is on the WBC again. What's the other molecule? One more molecule is CAM. We have one more molecule is CAM. There's two types of CAM, 𝐼_CAM and 𝐕_CAM. Like you said, na, I have E-selectin, I have P-selectin, two types. I have 𝐼_CAM and I have 𝐕_CAM. Perfect, Sarah. Intracellular cell adhesion molecule, vascular cell adhesion molecule. To that, your integrin will bind, right? Perfect, amazing. So it is bound. So next step is I have to move outside, right? What is this step called as? This step is simple. Transmigration or diapedesis, right? You know that for sure. Transmigration or diapedesis, right? Great. It goes outside. What's a molecule required for diapedesis? Actually, in our diapedesis, there are two steps. Only one step you guys always read. I'll tell both the steps here. The first molecule here is your PECAM1. Other name is CD31. That's the one which helps to escape. Superb. Have PCAM1. PCAM1 will help to squeeze outside. Have two steps in diapedesis. Very important. Can anyone tell me what layer is this? What is this layer? Endothelium rests on whom? What is that layer? Endothelium always rests on basement membrane, right? Basement membrane is made of, that's also PYQ. Basement membrane is made of, read with Angi. It's made of your collagen, right? So I want collagenase. MMP is a group, right? Here I require collagenase, which comes from the neutrophil. This neutrophil has granules, right? Neutrophil, there are granules. That granules will release collagenase, and that collagenase will not rupture, will create holes. If it ruptures, no, I'll have bleeding. No rupture here. Holes, so it goes via that, right? Yes, MMP is to some extent right, but the best answer will be I'll have non-specific collagenase. Why non-specific? If it's specific collagenase, again I'll rupture. If it's non-specific collagenase, I'll create holes, right? Two steps are here also. Non-specific collagenase and PCAM 131, with the help of it will come outside. Let's assume it came outside here. Now it has to move here, na? What's the name of that? It came outside, not enough. My organism is here. This is the streptococci. It has to go there. That is movement. Chemical mediated movement. Name is simple. Chemotaxis. Tell me few molecules which comes to your mind for chemotaxis. Endogenous, exogenous, anything. We have exogenous, one guy from the bacteria, lipopolysaccharide. I'm sure you know that. It's from the bacterial molecule. That is a perfect opinion. Right? C5A. One more thing. One more classical leukotriene. These two, if you remember, that's more than enough for me. Interleukin 8. Great. So all these are endogenous chemotactic factor. Interleukin 8. You have your C5A. You have your LTB4. All three are important. Fine. All three are important. These are chemotaxis. And finally, once it reaches to the place, it will undergo phagocytosis. Let's complete phagocytosis also. Why to waste? We came here, till here, it came. The next is phagocytosis and killing. Phagocytosis is just engulfing, right? So obviously our goal is how it's going to exactly kill. Killing happens inside phagolysosome, right? So now let's say for killing, the most useful mechanism is oxygen dependent or oxygen independent. What do you think is the best mechanism of killing? It is oxygen dependent mechanism, right? It's oxygen dependent is the best one. That's why we call the mechanism as respiratory burst. It will use oxygen and it will kill the organism. Respiratory burst, right? Now oxygen will be converted to O2 minus. So what enzyme is required? We have an enzyme. Yes, Upendra. You want for opsonization? C3b is a better opsonizing factor. C5 is for mostly for chemotaxis. Fine. Yes, opsonization also will happen. Then phagocytosis happens. You are right. You are right. I skipped that part. Fine. Okay. NADPH oxidase is the most important enzyme which converts O to O2 minus. Right. O2 na. O2's other name is superoxide. So what's the next enzyme? You know the answer. We have the next enzyme, superoxide dismutase. It will convert it to hydrogen peroxide. H2O2 is hydrogen peroxide. Hydrogen peroxide has two outputs. One based on MPO. MPO का मतलब myeloperoxidase, right? Yes, with the help of myeloperoxidase and chlorine produces HOCl. With the help of major basic protein and iodine, it produces HOI. This is where body is amazing. HOCl kills bacteria. It is bactericidal. Okay. HOI kills parasites. Okay. It's kill parasites. Now tell me, which WBC is required to kill parasites? Neutrophil or basophil or lymphocyte or eosinophil? Which WBC is required to kill parasites? Eosinophil, right? Simple. Why eosinophil? Because this one major basic protein which is required for me to kill parasite is there only predominantly in eosinophil. My body knows that. Only when I bring eosinophil, I can create HOI, I can kill the parasite. If I bring neutrophil, it produces this, which can kill bacteria. This is one of the most potent bactericidal free radical. That also is an MCQ. Okay, it's the most potent bactericidal, not for human beings, for bactericidal. Watched advertisements growing up? You must have. In Dettol, advertisement Dettol, Lysol, you'll be written 99.9% bacteria will be killed because Dettol has HOCl. Lysol has HOCl. You go to hospital, if blood spills, what do? Pour HOCl because it can kill really 99.9% bacteria. Very, very, very potent bactericidal. My neutrophil uses that to kill streptococci. Obviously, it will be killed. Once it is killed, let's assume it is successful. Inflammation should stop or keep on continuing. What do you think? That's the last part. Should stop or keep on continuing inflammation? Obviously, it has to stop. To terminate inflammation, we bring interleukin 10, anti-inflammatory, right? Resolvins, anti-inflammatory. Lipoxins, anti-inflammatory. Fine. And last but not least, TGF beta. This also is anti-inflammatory. Okay. TGF beta helps a little bit in healing process also. So it will automatically stop, right? That's a cycle, step by step, everything required for inflammation in a gist. Fine. Okay. Done. Let's go to the next question. Next is a very simple question. Everyone should answer. A, B, C, D. Okay, Upendran, read the question back again. I know that's a silly mistake. If it's a silly mistake, tell it's a silly mistake and change the answer. Because I don't expect you to answer A for it. No, it is chronic inflammation, right? Chronic inflammation, you don't see neutrophils, right? You see either of these two. I'm very, very happy all of you marked D, didn't mark C, because lymphocyte also is a sign of a cell of a chronic inflammation, right? But perfect, you marked D. Answer is D, because macrophage is a cell of chronic inflammation, right? Now, perfect, Rahul. Predominantly macrophage, lymphocytic plasma cells for some category. I'll come to that category soon, fine? Now, I'm just going to ask you a random question, not related to this at all, fine? Anywhere in the body, any organ in the body, can I say inflammatory diseases are the maximum? Acute chronic inflammation, take lung, pneumonia, interstitial lung disease, chronic. Take GAT, inflammatory bowel disease, acute gastroenteritis. Take kidney, glomerulonephritis, a big chapter. Na? Inflammatory diseases are important in the body. Half of the disease in every system, whatever system you take, is inflammation, right? And I have only 4 inflammatory cells, maybe a little bit one more. Neutrophil, eosinophil, lymphocytes, plasma cell, macrophages. That's all. Basophil is not that much useful. Very simple cell kept there. That's all. Only 5 inflammatory cells. If I know this 5 inflammatory cells, I can rule the inflammatory disease ka biopsy. That's what we are going to do. If I see neutrophil, it's acute. Done. Everyone knows that it's acute, or it could be bacterial related, right? If I see eosinophil, you know it could be allergy or hypersensitivity related, or it could be parasitic, right? If you see macrophages, it is chronic inflammation due to any cause. If you see lymphocyte, mostly if you see lymphocyte, you'll think of virus or an autoimmune condition. Okay. Same with plasma cells also. Fine. No comments, Ali. Fine. Same with plasma cells as well, right? So both plasma cells as well as lymphocytes will predominantly be seen in autoimmune condition or virus, right? That's all. So now next is, how do I know, identify them in microscopy? Microscopy identification is sort of difficult. Biopsy is difficult. The blood smear is easy. You know that, okay, lobed cell, chromatin thread, granules hai, neutrophils. In biopsy, I won't see that, right? So what you see in biopsy is this. Whenever you see a bent nuclei, right? Blue is nuclei. This nuclei is bent. It is not round. It is just bent. Fine. Never forget this slide. After the class, take a photo of this and keep a screensaver for a week. You will never forget it. Because you open your mobile minimum 100 times a day. Every time, no, see this. You will hate your mobile phone. Good for you. Bent nuclei. If the nuclei is bent, it is neutrophil. Anywhere I see this, it's neutrophil. Fine. Next. How does this look? Pink or blue? Blue. Can I say most of the cells are round? Round, na? That's all. If you have small, round, blue nuclei, it is lymphocytes. I am going with lymphocytes, not with plasma cell, because lymphocyte is a bit easy to identify. Plasma cell might be a bit difficult, right? Okay. Next. This. What is this color? Anyone? The pink granules, na? Pink granules. It should be granules. Pink granules, you call it eosinophil. You might be wondering why I don't go with nucleus. Fine. Related to pathology, definitely PTY. Because neutrophils has how many lobes? It's a classical bilobe nuclei, na? Headphone shape or spectacle shaped nuclei. Problem in biopsy, na? Biopsy is in a smear, you can see the lobes, right? Biopsy is a cut surface. Or if the nucleus is like this, you can cut it. If the nucleus is one behind the other, how many lobes you'll see? You'll see only one lobe. 2 lobes, 1 lobes. It's based on the axis of cut. Here also you can see, look at this eosinophil. There's eosinophil, only one lobe, only one lobe, only one lobe. I do have eosinophils with bilobed also, right? That's why don't grow with lobes, go with granules. Pink granules, eosinophils. That's all. Fine. Next is clear. Fine. Macrophage. Macrophage is a beauty. What's the function of macrophage? Everyone? What is the function of macrophage? We know the answer. It is, come on, tell. Phagocytosis. What does it eat? Dead cells, bacteria, सब कुछ. Whatever is dead, it will eat. Right? Perfect. Dead cells में what do we have? Do we have protein? No, because necrosis का function में there is protease. Now protease will undergo lysis. Do you have nucleus in dead cells? No. Nucleus also undergoes lysis. Right? Pycnosis, karyolysis. So what is the only thing I have in the dead cell? Layer, lining. Because it ruptured, it didn't lyse. What is cell membrane made of? What is cell membrane made of? You will understand what our textbooks mean now. Cell membrane is made of phospholipid bilayer, right? Cell membrane is made of. Cytoplasm will dissolve, Mohammed. Phospholipid, right? What is the color of lipid in biopsy? Just now we saw. Fat, lipid, color. Clear. Macrophage will have clear appearance. It will be clear. Now, have you ever told in your life the other name for macrophages to be foamy cells or foam cells or foamy macrophage? Why did we call them foam? Because foam is clear. Unfortunate thing in medicine, na, we don't ask questions. We need to ask the right questions. Why foam? Because it's clear. Why clear? Because made of lipid. Why lipid? Because it's eating lipid. That's the function of macrophage. Macrophage are dubbed as foam cells because of the cytoplasmic color. That's all. This slide is important. Bent nuclei, small round blue cells, pink color, and clear macrophages, right? Now with this slide, I'll ask you questions. You have to answer the questions. It's going to be very simple questions. I never ask difficult questions. Very simple questions extrapolating from this. Fine. Okay. I am giving you a glomerulus ke biopsy. Okay. In the glomerulus microscopy, you are seeing bent nuclei. Lots of bent nuclei inside the glomerulus. Tell me the diagnosis. What's a diagnosis? Simple diagnosis. Whatever comes to your mind. Start from basic. Bent nuclei means, who's the guy? Neutrophil, right? So neutrophil in glomerulus means, Upendran, great, but AKMA you have necrosis, na? You might not have much of nuclei, and AKA is tubules finding, not glomerulus finding, right? Upendran and Boster QT, AKA is an, again, Sara, pyelonephrid is a tubules finding, not glomerulus finding. I'm talking about glomerulus. Glomerulonephritis, right? Perfect, Aman. What could be the etiology of this glomerulonephritis? Bacteria, virus, autoimmune. Step by step we'll go. It's neutrophil. Perfect, Utkarsh. What could be the etiology? Bacteria, virus, autoimmune. You can do it. Bacteria, superb. Tell me the disease. Beyond this, I won't help. It's an acute glomerulonephritis based of because of bacteria. What's a disease? Disease is right. It's right there. The bacteria is superb. That's all it is. PSGN. Done. You just need a little bit of time. That's all. And a little bit of common sense. You can diagnose PSGN with just bent nuclei. I don't want anything. Microscopy is easy. Let's extrapolate one more. I'm giving you a thyroid FNAC, right? Generally, we don't have biopsy in thyroid, right? So we have a thyroid FNAC, right? In thyroid's FNAC, you are seeing lymphocytes. Lots of lymphocytes and plasma cells are seen. Okay? What could be the answer? Lymphocytes, again, I should have not told lymphocytes. Okay, small round blue cells are seen. Lymphocytes, na? Okay. I'll come to it, Aman. I'll come to it. Give me a second. Have? Sarah, great. You jumped a step. You should have told autoimmune, na? Hashimoto is great. Can I say could be an autoimmune thyroiditis? Because I'm sure you don't know any viral thyroid infection, na? It's an autoimmune, right? I'm not talking anything. It's just autoimmune, right? Perfect. Now, I'll change the question two ways. The patient is hyperthyroid. What could be the answer? And the patient is hypothyroid. What could be the answer? See, this is what correlation means. Before jumping to Hashimoto, you must have asked me thyroid function test ka value, right? And if the patient is hyperthyroid, I think of Graves. The patient is hypothyroid, I think of Hashimoto. You're right. But I need a little bit of more information. Don't jump till I have every information, right? Okay. Aman, coming back to your question. PSGN is not due to immune complex deposition. PSGN is due to planted antigen. Which antigen? Streptococcus K antigen. For that, my body develops immunity. So the problem here is bacteria's antigen. Body will always react with bacteria's response only. It will produce antibody. It will go and bind to the bacteria, destroy it, and by default, neutrophil also will come. Fine. It's not immune complex deposition. It's a planted immune complex. Both are different. Circulating immune complex in SLE, planted immune complexes in PSGN. Fine. Perfect. Simple. Now we can extrapolate. Next. Just one more finding. Macrophages are lots seen in the tunica intima of the vessel. All clear cells in the tunica intima of the vessel. Diagnosis. What's the diagnosis? Simple, na? Most welcome. It is atherosclerosis. Macrophages, chronic inflammation of the blood vessel has to be an atherosclerosis, no? Vasculitis should be chronic, right, Rahul? Chronic vasculitis, I think of an atherosclerosis. As simple as that, right? Perfect. Next one. Answer. It's a simple question. See, this is a very basic question. I'll tell you why I put a very basic question also. I think why it's not required for us. Huh? It's a low cell count. Nah? Question is all except. Exudate is all except low cell count by default, right? So generally we always go for the PYQs and PYDs, no? Last NEET PGM, there's a question on filariasis. Simple filariasis. Quite a few people made a mistake because they ignored basics. You have to know about few things always. See, these are all you have to know. Specific gravity. There's no excuse if you don't know specific gravity. No excuse if you don't know the difference between exudate and transudates, right? These are very basic thing which has to be known, right? Which of these two is inflammatory? Exudate or transudate? By default, exudate is inflammatory, na? Whenever you have inflammation, it's exudate. Transudate, no, most of them are non-inflammatory edema. Both are edema, both are fluid, both are coming outside. It is non-inflammatory, right? So in which condition do you have transudate? Often, variegated is generally meant for clear cell RCC, okay? But I don't find any problem for you to differentiate clear cell RCC and Wilms because age. Wilms is a tumor seen in children. It is not at all a differential diagnosis for clear cell RCC. Fine. Both are very different. Any disease which has hemorrhage into it, we call it variegated appearance. Fine. Okay. The best example is, let's say, pleural effusion or pulmonary edema secondary to your heart failure. Fine. We call it exudate. A simple bacterial pleural effusion, we call it transudate. Sorry, we call it exudate and transudate. Sorry, I Made a mistake, fine. Okay. You must have definitely read in your medicine about Light's criteria. Light's criteria is based on your exudate and transudate only, right? In exudate, there'll be lots and lots of cells. If the cells are more, by default, there'll be more protein. No. Cells is there, more protein also will be there. If cells protein is more, then by default will be more specific gravity. That's as simple as that, right? So I have high protein content, high specific gravity, and presence of inflammatory cells. That's for exudate. It's coming outside. All the cells, proteins, everything is coming outside, trying to destroy the organism, right? Here, it's all the reverse. Almost nil cells. I cannot say zero because sometimes 1 or 2 WBC can escape, but almost nil, right? So protein content again is very, very, very less compared to an exudate, very less, and specific gravity also is less. If you want to remember the number, great, 1.1 1.020. Otherwise just straight specific gravity will be low. That should be more than that, right? There's a very basic difference. You might not read these differences in your entrance prep. You must have read this long back in your MBBS, right? That also will hold true. That also will help you, right? So don't ignore MBBS. MBBS is required for all your juniors. Please tell them MBBS is very much important. Entrance prep is also very much important. Fine. Next, we already discussed these questions, so we'll quickly go through at least few of them. Adhesion molecule responsible for leukocyte rolling. Simple, na? It is undoubtedly selectin, right? We had E-selectin, we had P-selectin. Actually, the selectin, na, L-selectin. L-selectin is not useful. L-selectin has no major role in inflammation, very minor role, right? And there's one more question, right? With respect to selectin, this is an old question. I hope you might know that. P-selectin, na? P-selectin is present both in platelet and also in endothelium. Okay? So in endothelium, P-selectin is actually stored in a place along with your von Willebrand factor. Can anyone tell me what's the place of that? P-selectin and von Willebrand factor is stored inside the endothelium in a space. We call it, starts with W. If you have heard, great. If not, remember them. We call it Weibel Palade bodies. Fine. So Weibel Palade body is a structure inside the endothelium which stores P-selectin and von Willebrand factor. Von Willebrand factor helps in your bleeding and clot formation. Fine. I hope you know that. Fine. Okay. Okay. Next. Which cytokine is a major mediator in fever? It's a simple question. No, actually rest three are totally unrelated. Healing, right? Tumor necrosis factor to some extent, yes, but the major one is by default interleukin 1, right? Interleukin 1 is the major guy. There are three major guys involved. Interleukin 1 is there, interleukin 6 is there, and tumor necrosis factor is there. Fine, TNF. So all these three now goes to the liver, and this instructs the liver to produce many proteins. So many proteins will be produced more. Some proteins will also be reduced, right? So what do we collectively call these proteins? We call them acute phase reactants or acute phase proteins. Both means one and the same. Please remember, acute ka matlab, it's not just seen in acute inflammation. It is seen both in acute as well as chronic. That is important for us to remember. It is seen secondary to inflammation, not just in acute. It is increased both in acute as well as chronic. Because in chronic inflammation, interleukin 1 is chronic. So it keeps on telling the liver, keep on producing more and more of these guys, right? So there are few acute phase reactants which I want you guys to know because they have utilities. They have applications in real life. Isliye we have to know these guys, right? Fibrinogen is all these now, all of them are positive acute phase reactants, meaning the value will increase during inflammation. It will not reduce. It will increase during inflammation. That's why we call it positive acute phase reactants, right? Fibrinogen. Can anyone tell me the use case of fibrinogen? Increased fibrinogen kind of reduces or increases the settling of RBCs. They neutralize the charge on the RBC and they settle the RBC faster. What is the test based on it? You guys know the answer. What's the test based on it? It reduces the charge, so it makes the RBC settle faster. So what will happen? You'll have elevated ESR. Though not a useful one, ESR. ESR, right? Erythrocyte sedimentation rate. Now, let's correlate one more thing. What will happen to fibrinogen level in pregnancy? Elevated? Reduced? Obviously elevated, na? It is. ESR is also elevated in pregnancy because more and more fibrinogen, more and more settling, right? One more superb correlation. This interleukin 6, no. This interleukin 6 increases fibrogen any which way. So when I have very fast sedimentation, okay? Sedimentation means it is settling, right? So normally in a peripheral smear also they will settle like this. There's a very high fibrinogen, there will be very fast sedimentation, and the peripheral smear also it will settle RBCs. What is this called as? We call this rouleau formation, right? Which disease? You must know the disease. At least one disease you know. The worst. Multiple myeloma, right? In multiple myeloma, there's rouleau because in multiple myeloma, there is more and more interleukin 6. That is the reason. Rouleau can also be seen in sepsis because more fibrinogen due to inflammation. Fine? Perfect. Next guy. Ferritin. Ferritin, if you have been around COVID, if you have seen some of your relatives or neighbors affected by COVID or you yourself, that's one of the very useful acute phase data, right? If ferritin is elevated, which indicates by default severe inflammation. Same with your CRP also. These two are very commonly used. Ferritin and HS stands for highly sensitive CRP. CRP, C-reactive protein, right? Both are very useful for any inflammation. We do them to tell the severity. Sometimes if you want to admit some patient, I'll be look based on that, right? A protein. A protein is serum A protein. Okay. The only reason I've put this is there's a disease where you have in chronic inflammation, there's a type of amyloidosis. Can anyone tell me what is the name of amyloidosis? In chronic inflammation, like AL amyloidosis for multiple myeloma, what's the type of amyloidosis for chronic inflammation? You should know that. That's a PYQ. What's that? Chronic inflammation, what type of amyloidosis is that? You have A amyloidosis, na? Right? That's this A protein. Serum amyloid A protein will be deposited, right? Utkarsh, A beta 2 microglobin is seen in chronic hemodialysis induced amyloidosis, right? Chronic inflammation amyloidosis, you'll have AA amyloidosis because of A protein getting deposited more. Fine? Okay, that's also an important thing, right? These are positive. Just for MCQ, there's something called as negative acute phase proteins or acute phase reactants. Fine? Negative acute phase reactants, one important thing is albumin. इसका मतलब albumin ना, and one more thing called as transthyretin. These both reduce in quantity during inflammation. At the time of inflammation, the amount of these reduces. That's why we call it negative acute phase reactants. Fine? Perfect. This is just related to your interleukins and the acute phase proteins, which are very useful in real life. Fine? Okay. Next one. What's the answer? Do you know the answer? It's a very simple one. We already read the entire thing. Just a small scenario-based question based on that. Appendicitis, histology shows migrating tissues through the endothelium. It's nothing but everything is clearly given. Transmigration or diapedesis. 2 steps, just remember that. MMP, if you remember, great. Collagenase and also PECAM or CD31, right? Nothing much to discuss about that. So we'll take this opportunity to discuss the abnormality, the diseases. What are these two names? The name of these two diseases, if Cialis X is absent or if integrin is absent, we call it LAD, right? Leukocyte adhesion deficiencies. Remember, this is a leukocytes problem, right? That's why Cialis. Please write in big letter, not selectin. Because what comes to our mind always is selectin. That's what comes to my mind now. Selectin K defect, right? But it's Cialis X defect, right? Both are leukocyte adhesion deficiency. This is LAD2. I looks like 1, so it is LAD1. Fine. Leukocyte adhesion deficiency 1 and the other one is leukocyte adhesion deficiency 2. One classical finding for both. Great. Utka said that first one, right? It is associated with Bombay blood group. Again, a rare finding, but yes. Or the H group. One more finding. For integrin K defect. A problem with, see, integrin, na, it helps in wound healing. If integrin is defective, wound healing will be slow. Wound healing will be incomplete. So scar formation will be defective or delayed. What is the first scar you and me got? Anyone? Everyone is the same scar. Everyone the same trauma. Umbilical, right? It's a delayed separation of umbilical cord. Because umbilical cord is a trauma. It's a scar. Umbilical is a scar, no? So obviously it will not be properly healing. Slowly it will take time because of the integrin K defect. That's a reason behind delayed separation of umbilical cord. One more important thing and a very unique thing which I want to say, both of the disease will have neutrophilia. I'll tell you why it is unique. See, can I tell both of them are immunodeficiency disorder? No, they are immunodeficiency. Every immunodeficiency disorder, we should have reduced WBC. But here, there is very high WBC. Yes, a recurrent infection like Syed said, immunodeficiency, but they have neutrophilia. Because here the problem is not protection of WBC. Exit of the WBC is the problem. That's why you have neutrophilia here. Fine. Okay, NAD Apoptosis, what defect? What disease? Chronic granulomatous disease. Two important pointers not to forget. What infection? Catalase positive, catalase negative, both. What infection? It is predominantly catalase positive infection, right? Very important, like streptococcus, staphylococcus infection. Recurrent catalase positive infection, CGD. Like someone said, Fox gene mutation. If you want to add that, great. Fine. One test, some blue. What test is that? That also is one of the diagnostic tests here. Okay. Here I have two inheritance, autosomal recessive and X-linked recessive, two types of inheritance. Fine. We have a test which is called an NBT test. Nitro blue tetrasolium test. That's one test which can help in diagnosing your your NADPH or chronic granulomatous disease. Fine. Okay. Phagolysone defect. What's the disease ka naam? Here there is a mutation in a gene called as LYST gene. See, everything is easy if you understand what it is. LYST, full form is lysosomal transporter. Phagosome, lysosome. Lysosome should move here, unite to form phagolysosome. For this moving, I need transporter. If I don't have the transporter, it won't move. So, phagolysosome formation will not happen. Simple. LYST is lysosomal transporter defect. Like Sarah said, the syndrome is Chidiac-Higashi syndrome. Fine. Classical finding is your immune dysregulation by default, right? One more important finding. What is that? I'm sure you guys know that answer. One more classical symptom of Chidiac-Higashi apart from infection. Apart from infection, this finding is very, very important. Everyone knows the finding. What's the finding? Patient will have albinism. Okay. And there's one specific finding for Chidiac-Higashi, which is microscope you will see giant granules. Okay, you'll have giant granules in microscopy, right? Thing why I am forgetting is I am not able to understand why albinism. If you know why albinism, you will never forget. What is the origin of melanocytes? Is it an epithelial derivative or a neural crust derivative? Melanocyte. Melanocytes origin is neural crust derivative. Na? That's also a question in your anatomy. So for my melanocytes to come here, to come to my skin, it has to move from the neural crust. I have melanocytes here. You have here. You have in your tip of the toe. It has to move. Movement ke liye what is required? LYST is required. So if LYST is not there, the melanocytes cannot move from the neural crest. If they don't move, will I have albinism? By default, I'll have albinism. It's spliced genes defect. So wherever it helps in movement, those defects will be there. That's all fine. MPO deficiency, nothing much to remember. Very rare and not that severe also. Nothing to remember much. Here you'll have catalase positive as well as catalase negative organism key infection. Okay. This is also an important table. If a question comes from this, we'll be more than happy. Fine. All the disorders of inflammation, what we need to know. Okay. Next. What's the answer? It's simple, na? Actually, not the right answer, but the most appropriate answer here is it's a T cell problem, rheumatoid arthritis. You have a granulomatous inflammation, right? Perfect, right? So we will take this opportunity to read about granulomas. That's all. Okay, this is a granuloma. Can anyone tell me necrotizing or non necrotizing? Necrotizing, not there, na? Because everywhere I have blue color. If blue color is there, na, it's non-necrotizing, right? This entire structure is granuloma. In the center of the granuloma, we'll have your epithelioid cells or epithelioid macrophages. Please remember, these are the principal cell of granuloma. That's the most important principal cell of granuloma. The corner mate, you tell me, I want everyone here to answer. What cell is this? We just now saw the 4 cells, na? Quick recap. Bent nuclei, neutrophil, pink granules, eosinophil, small round blue cell, lymphocyte, clear cytoplasm, macrophages. What cell is this? Perfect. You should have lymphocytes in the corner. Okay. These are epithelioid macrophages. That's a principal cell of the granuloma. The function is not phagocytosis, unique. Macrophage which does not eat. The function is secretion. They secrete interleukins, cytokines. That also is important. Perfect, Aman. T lymphocyte is exactly right. But lymphocyte is more than okay because microscope I cannot say B or T without marker. Right? So now I have to differentiate this. Most of them questions do come in this tables. The problem with tables, I keep on forgetting tables. Again, I don't read why I differentiate. First, this is important. Both the first diagnosis is TB, only TB. Till you are in this world, not even India, in the world, granuloma is equivalent to TB unless otherwise proved. Be it necrotizing, non-necrotizing, doesn't matter. Okay. Now tell me, let's know the base of this table. What is the definition of necrosis? Live cell or dead cell? What is necrosis? Necrosis means dead cells, na? Necrosis is equivalent to dead cells, right? Okay. So it's a dead cell. When will I be having cell death? Only when I can kill the organism. Yes. Okay. So if my immunity is great, able to kill the organism, I can produce necrosis. TB may I can kill it. Necrosis. Can I kill leprosy bacilli? Obviously. Pure neuritic variant of leprosy, I can kill leprosy. Necrosis hai. Right? Can I kill histoplasmosis? Obviously, my immunity can kill histoplasmosis. Necrosis will be there, right? In other words, I can kill. If I can kill necrosis, can I say sometimes my immunity is not that great? I can't kill TB. Possible hai? So a patient is having TB and HIV. Immunity थोड़ा कम था ना, I cannot kill. So, possible. Because TB is very common, this possibility exists. I'll give you one more case. You must have heard about coal workers pneumoconiosis, na? Lungs may coal workers pneumoconiosis, silicosis, asbestosis. Can my body kill coal or kill silica or kill asbestos? They are already dead, no? Nothing to kill. So all the occupational lung disease, I cannot kill. I cannot form necrosis. Has to be non-necrotizing. I can't kill them. Can I kill a suture material? I can't kill because there's no life to kill. I cannot kill any foreign body. So foreign body granuloma is non-necrotizing. I can't kill a foreign body. Nothing to kill in a foreign body. There's nothing to kill in Hodgkin's lymphoma. Non-necrotizing. There's no organism to kill in Hodgkin's lymphoma, right? These are cells, right? So Hodgkin's lymphoma, right? Nothing to kill there. There's nothing to kill in sarcoidosis, non-necrotizing. If I can't kill, non-necrotizing. If I can kill, necrotizing. That's it. That's the easiest difference I want you to know, right? And please remember, unless otherwise proved, don't jump to sarcoidosis, always TB. Think of sarcoid if there is a bilateral hilar node involvement, classical chest X-ray finding of sarcoid, and the most important, there are two more findings. Hypercalcemia is common in sarcoid, and the most important finding is there will be elevated angiotensin converting enzyme, ACE. If these three are there, suspect sarcoid. Otherwise, sarcoid is the last. Okay, fine. Okay, few more images. You know these images. Just a quick recap of them. Fine. What is this? A classical Jane cell. What Jane cell is this? That's a classical Langerhans Jane cell. Findings in TB. Right. A U-shape or a horseshoe-shaped Jane cell. Na? Okay. What is the Jane cell? Jane cell where nucleus is in the form of a circle or a wreath. Okay. A wreath-like arrangement or a circular arrangement. We call this two-tone Jane cell. Okay. It is seen in a condition called as xanthoma. Fine. We see them in xanthoma. It's a condition where you have lots of lipid accumulation, like tendon xanthoma, skin mesenchyma, like hyperlipidemia, you will see them. Fine. Okay. You know this as well. What is this? It is irregular stellate. Actually, stellate granuloma is not the shape. Stellate granuloma, in microscope, you'll have neutrophils also. You'll have neutrophils and granuloma. Very unique, right? And that is the biggest thing about stellate. You'll have neutrophils plus granuloma. That's why stellate granuloma is very, very unique. That's classical of stellate, right? Which condition? Next one also you definitely will know. Donut, right? Donut shaped granuloma, which condition? Stellate granuloma, which condition? One, you know for sure, cat scratch disease, Bartonella Hensley infection. One more thing, do remember, LGV, lymphogranuloma venereum. There also you'll see stellate granuloma. Remember, fine. Donut is by default two things here also. Q fever you will see. Also one drug toxicity, allopurinol toxicity. That also you see stellate granuloma. And stellate is more commonly seen in bone marrow and liver. Because when there's fat, stellate's shape is because of the fat in the center. Okay, fine. Done. Okay, there's few things about granulomatous inflammation and granulomatous images if it comes in exam. Okay, next. Till the right answer. C. Okay, it's a simple one. Remodeling phase, type 3 collagen is getting converted type 1 collagen. See, normally in wound healing, type 3 will be seen in the time of granulation tissue. From the moment from granulation tissue, to it starts becoming scar tissue. It will slowly become a type 1 collagen and slowly it remodels as well, right? Fine. We'll just have a quick look at the healing, the timeline for primary intention, right? Okay. So the first immediate event is healing by primary intention. Primary intention का मतलब, you know that it's a simple, clean, uncontaminated wound, right? Or a simple, the best example is a surgical cut, or if you shave, tiny cut, should not be infected, no tissue loss. It's a primary intention. Immediately you have a clot formation. Clot, or we call it scab. Very, very important phase. Your mother knows more medicine than we can ever know, because medicine is about experience. Medicine is not just knowledge. Have your mom told this? When you're a child, when you fall down, there'll be a brown color structure. Huh? Your mom will say, don't scratch because it will itch. If you scratch, it will bleed. It will start healing from the first. That is nothing but scab. That's the most important base for wound healing, right? Who's the first cell who comes inside? The first cell is neutrophils. Neutrophils will come into the wound. The job is to remove debris, remove any bacteria, remove any debris. That's the job of neutrophils by default, right? After neutrophils removes, who will be the next person coming inside? Big boss, macrophages. Okay? Macrophages comes inside. Macrophage will try to remove neutrophil. Fine. It removes neutrophil. That's a first job. After that, inflammation is over. Na? It should help in the healing also. It will also get converted to activated macrophage, and they start secreting few substances involved required for wound healing. Okay, they secrete two important guys. One is VEGF. What's the function? And one more thing is FGF. Second group is TGF beta and PDGF, platelet derived growth factor. Okay, what's the function of VEGF? Vascular endothelial growth factor. Na? It produces blood vessels. This produces neovascularization. That's classical. Function of TGF beta brings fibroblast, produces collagen. The initial formed collagen will be always type 3 collagen. So what is this tissue called as? Lots and lots of new blood vessels and newly formed collagen. Very fleshy also. We call it granulation tissue. A very, very classical tissue. A hallmark healing tissue. If you disturb this also, I have a problem. After that, what will happen? The same type 3 collagen gets converted into type 1 collagen. So type 1 collagen is the permanent collagen which results in the scar formation. After formation of scar also, I have remodeling process, where again my matrix metalloproteinases comes and keeps on removing the old one, lays the new one, old one, lays the new one, right? This is the classical timeline of healing for healing by primary intention. If it is healing by secondary intention का मतलब there's two things. One, there's tissue loss. I have loss of tissue, or second, I have an infected wound. Even if it's a clean thing, there's an infection present. So it's healing by secondary intention. Fine. Okay. Second intention step will be the same. Neutrophil, macrophage, granulation tissue, scar. The timeline alone will change because lots of tissue loss is there. So neutrophil will take a little bit extra time. Macrophage will take a little bit extra time. I have to bridge the wound. Your collagen formation, vessel formation also will take time, right? So only thing is time changes. Okay, perfect, fine. Next question. Same thing related to whatever we saw in wound healing. 2-3 questions related to that. Simple. There are two things here. Both of them help in the wound healing process. So both of them help in the fibroblast process. But what is more important is this guy. Okay, this is the most fibrogenic. Very, very, very important. PDGF also is, But the best answer will obviously be TGF beta. TGF beta is a very, very, very pro-fibrinogen peptide, fine? Okay. Let's have a quick look at the scar formation and the problems in scar formation, fine? Because if wound healing is not proper, will result in abnormal wound healing. And these two, na, Sandeep sir, surgery guy, he also will talk about that, fine? Okay. What happened, Phoenix? You have changed the name and come back. Please, not here. Fine. So hypertrophic scar and keloid formation, fine. Ethnicity of hypertrophic scar, there's no racial disturbance. Keloid formation is more common in Indians and also in Africans. How many of you here have keloid formation? How many of you here have keloid formation? Quite a few. I have keloid. This is a keloid. It's been there for almost 10 plus years, right? It's not going away. Right? It's a keloid. It's an abnormal scar tissue, that's all. Symptom, nil. Here also it can be nil, or sometimes it can itch and also cause pain. Okay. It may itch, is cause pain. Sometimes it will be asymptomatic also. How do you confirm it's a keloid? There are few locations where keloid is very common. Earlobe, it's very common. In this precordium, it's very common. Fine. Diagnosis is simple. Examine the wound. Microscopy is not required. Let's assume this is the wound. Okay, there's a gap. If the scar is within the wound, okay, this red color is the scar. The scar has not crossed wound margin. That is classical hypertrophic scar. If the scar has, see, this is the wound's margin, no? Scar is like this, crossing the wound margin, fine? If it is crosses wound margin, that is classical keloid. You can easily see, if you have seen keloids, a single prick, tiny prick can make a big keloid. It will definitely cross the wound margin. This is diagnostic. Microscope is not diagnostic. How you treat keloid? Anyone? If you tell this, I'll tell a very, very interesting correlation. How do you treat keloid? How do you treat keloid? By giving intralesional steroids. In intralesional triamcinolone, this just reassure. You need not treat reversible is hypertrophic or reassure, right? You give steroids to them, right? If it's here, I have to inject steroids here. Why? How does it act? Simple. Steroids is, well, reduce TGF beta because it will reduce inflammation. If TGF beta is reduced, there will be reduced collagen. That's how we treat it, right? Very, very simple. And also destroy the collagen, right? The interesting correlation here is, what is the treatment for COVID? What's the treatment for COVID? COVID's treatment. Treatment of COVID was to give steroids. That was the primary treatment, no? Why? COVID caused fibrosis in the lung. The only way to stop fibrosis in the lung is stop fibrous formation, stop collagen formation. The moment you stop collagen formation, automatically fibrosis will stop, right? That's how we treated COVID, right? That's how we treated COVID. It's just the basic things. If you know basics, even the worst disease, what we have seen in this generation, can also be treated. Basics are important. They understood the treatment of COVID. After post-mortem, looking at the lung, there was fibrosis. Give steroid. If you exactly look, when we gave steroid was around first week. Why around first week? Because every wound around first week will start producing fibrosis. Stop it by giving steroids. That's all COVID is, right? Very, very simple thing, right? Perfect. Next one. A simple question again. Just a simple question to make sure that you listen to this discussion. What's your answer? Simple one, na? Minimal scar formation, no significant contraction, and clean surgical incision has to be healing by primary intention, right? Nothing much to discuss about it. healing by primary adhesion. Secondary adhesion is your wound with tissue loss or wound with infection. Fine. Just a fact for us to remember. Trisomy 21. Tell me the answer if you know, and also tell me what syndrome does it cause. What syndrome does trisomy 21 cause? That's a simple question, right? It causes Down syndrome, right? Down's is trisomy 21. Can anyone? There are only 3 trisomy known to mankind: trisomy 21, trisomy 18, and trisomy 13. Okay. Anyone? What is trisomy 18? What syndrome is trisomy 18? Trisomy 18? You're right, Sanjeev. What is trisomy 18? We have Edward. Okay. 18, Edward. E for E, if we can remember like that. 13 is Pathology syndrome. These are the only 3 trisomies known. And the answer for this is maternal meiosis 2, meiotic non-disjunction, is the reason for Down syndrome. Fine. One question, and there'll be follow-up questions to that. Fine. Sorry. What is Down's inherited or is Down's sporadic? Down's is inherited or sporadic? Down's is sporadic. No, Down's is not inherited. Down's is sporadic. What is sporadic? Sporadic means anyone in this world can have the disease. It's not an inherited condition, right? That's why we always say the most common cause of intellectual disability is Down's. But the most common IDs for intellectual disability or the older term of mental retardation, right? Most common inherited cause of intellectual disability is Fragile X syndrome, because Fragile X is inherited. Down's is not inherited, right? Anyone can have Down syndrome. What is the risk of Down syndrome? Why do babies have Down syndrome? Down's has only one risk factor, the predominant risk factor, that's your mom's age. Mom's age of more than 35 years is generally considered a risk factor for Down's, right? One leading question to this. Great Utkarsh. Why not dad's age? Why mom's age? Same in the question also. Why it's actually maternal? Why not paternal? Why mom is involved? Why not dad? Don't say it's a patriarchal society, so it's like that. It's not like that. Science, it's pure science. The answer is there in your epidemiology, right? Sorry, answer is there in your embryology, not epidemiology. If you remember, when does oogenesis start? Intrauterine life or after puberty? Oogenesis. It starts in the intrauterine life, right? Oogenesis starts in the intrauterine life when a female is being conceived, when the fetus is growing. That time itself oogenesis starts. So the ovum of a 35-year-old mother is 35-year-old ovum. It's not a new ovum. Here, it's a very old ovum. Anyone old tend to make mistakes. The same way, it's having errors during meiosis. That's all. But the only advantage of men is spermatogenesis starts after puberty. Let's assume for ease of calculation, 15 years is the puberty age. 35-year-old man will have 20-year-old sperm. New. Okay. Great, Chaudhary, all the best. Fine. So this is the reason for maternal age group. Right? This is the most common risk factor. 95% of Down syndrome is due to maternal meiotic non-disjunction. This also came in exam. 4% of Down syndrome is due to one more thing called Robertsonian translocation. Fine. Okay. Robertsonian translocation. How to identify Robertsonian or not? In this, mom's age will be normal in clinical scenario. It's a translocation. Second finding is there will be no trisomy here. The person will have 46 chromosomes only. There will be no extra chromosome, only 46 chromosome. Normal Downs will have 47 chromosomes. Here there will be 46 chromosomes, right? Robertsonian translocation is nothing but it's a translocation between two acrocentric chromosomes. Can anyone tell me what does acrocentric mean? Where I have a big Q arm and a very, very tiny P arm. That is acrocentric. The commonest translocation is 1421. Okay, this is the commonest translocation in Down syndrome. Both of them are acrocentric chromosomes. Fine. Okay, that's few things about Downs which I want to talk about. Okay, diagnosis. Diagnosis. What's the answer? B. B. See, you know B or you already know the answer, so you're saying B. Correct is B, but I did a mistake. Okay, Utkarsh. Utkarsh, 5 minutes. Next 5 minutes, I can write and give you. You will never make any mistake in any pedigree in life. Just 5 minutes, listen to me. It's a statement. Because what we are going to read is not what I said, not what is there in Robbins. We are going to read what Gregor Mendel said, the father of genetics, right? We learn from him, right? There are only two things in pedigree. Whenever you see a pedigree, first thing, please never forget this. First thing is rule out mitochondrial. Because mitochondrial is non-Mendelian inheritance. It's not Mendel's, it's non-Mendel. How will you rule out mitochondrial? If mom is affected, all children are affected. Now, if dad is affected, no children affected. Whenever you have any pedigree, please see this first. Always, nothing else. Just see, okay, mom affected, okay, not all children affected, not mitochondrial, right? This child is not affected, right? Not mitochondrial. Dad affected, okay, two kids are affected, not mitochondrial. The first and the foremost thing is any pedigree, any time in life, rule out mitochondrial. That's the first. So if it is not mitochondrial, then I have two flowcharts. These two flowcharts I want you to read the day before the exam because you might forget it because you don't apply it daily, right? There are two flowcharts of pedigree, that's all. To understand this flowchart, I need one basic information. See, most of the time if you have seen a pedigree, it will be like this, no? Like it will be in multiple steps. And all these are called as generations. One generation. Okay, fine. So you have to ask only one question. If all generations are affected or not, which means, can I say in this pedigree, all generations are being affected? Is that statement right? In this pedigree, all the generation affected? Yes. At least one person every generation is being affected. Now I'll show you this pedigree, our pedigree. All generation affected or not? Yes, no. In this. Yes. Clear? I want everyone online to answer. All generations is pedigree affected or not? If you know this, pedigree is done. Yes, that's all, right? So that's what the question I want you to ask, fine? The first flowchart. If the answer to this question, okay, all generation being affected, if the answer is no, there is skipping of generation. I am dealing with recessive disorder. If you know recessive, only one question. Whether the affected person, everyone is males. Only males affected, X-linked recessive. Both genders affected, autosomal recessive. That's all. Fine. Rule out mitochondrial, all generation affected, no recessive, both gender autosomal, only men affected, X-linked recessive. Very simple. Next. If all the generations are affected, like in our question, assume that all generations are affected. Fine. Then I'm going to ask two more questions. That's all. Okay. If it's yes, my answer is dominant disorder. The next question is dad to son transmission. Right. Just assume I am having an X-linked disorder, X-linked dominant disorder. I'm giving birth to a son. For me to have a son, what chromosome should I give? You tell me. For me to have a son, what chromosome should I give? X or Y? Very simple question. Boy's chromosome is always XY. Girl's chromosome is always XX. I should give Y chromosome. Super. So tell me, is there any way I can transmit my X-linked disorder to my son? Yes, no. I can never. Because if I give my X chromosome to the zygote, it becomes a girl child, not a boy child. So there'll be no dad to son transmission in X-linked dominant. I cannot transmit. It will never be a boy child. It will be a girl child only, right? So that's my first thing. If I'm thinking of dominant, I ask the first question, okay, maybe X-linked dominant. If there is a dad to son transmission, answer is straightforward, autosomal dominant. Because in X-linked dominant, dad to son never happens. If it happens, autosomal. To confirm it is X-linked dominant, I ask a second question. Same example. I have a X-linked disorder. My X chromosome is abnormal. I'm giving birth to a girl child. What chromosome will I give? X chromosome. Let's say I produce 10 girl zygotes. Can I say all the 10 will have the faulty X? Yes. All the 10 will be affected? Yes or no? Absolutely yes. Because my X is abnormal and I have only one X, right? So all daughters of the affected dad, that's 100%. If they are affected, it is X-linked dominant. To confirm, no goes back to autosomal dominant. Just two flowcharts. These two flowcharts are more than enough for you to solve any pedigree. We already have one pedigree in the question. We'll look into that soon. We'll look into the other pedigree also. Okay. I have two more pedigrees here. You have to answer one by one. All generation affected or not? Yes, no. Just answer yes, no. That's enough for me. All generation not affected. Please don't ignore the first generation. Most mistake what you do is this. All generation not affected, right? Not affected. That's a mistake. It's not affected. If it is not affected, dominant or recessive, answer that. Please don't ignore this. Don't forget this. That's the first generation for me, right? It is recessive. If it is recessive, I'll show you the flowchart. I have only one question left, right? All male or male and female? Let's go to the pedigree. All male or male and female? Men, women, both are affected. It is autosomal recessive. Done? That's it. Let's look at one more pedigree. All generation affected or not? Yes or no? If you find it's difficult, you have to answer. All generation not affected. Please don't forget the first generation, right? No means dominant or recessive. It is recessive. If it's recessive, I have only one question. Both men and women or only men? Here it is. Only men, na? Only men is affected. If it's only men, the answer is X-linked recessive. That's all. Simple, very simple. Right? Now let's go to our question. Our question is what you have the pedigree? This one, na? All generation affected or not? Answer is yes, affected, no? Obviously. Dominant, recessive. Dominant, right? Perfect. So if it's dominant, let's go to a flowchart. I have two questions in dominant. What's the first question? Dad to son transmission, present or not? Let's go back to it. I'll come back to it, Rahul. Just give me a second. Fine. Dad to son transmission, present or not? Dad is affected, son also affected. Yes. If it is yes, it can never ever be X-linked dominant. It has to be autosomal dominant. Because, same example, I'm a dad. I can never give my X chromosome to my son. I will give Y chromosome to my son. Simple, done. Every pedigree what you solve will be fitting into this rules because these are Gregor Mendel's rules, not my rules, right? And the only thing, rule out this. You'll make a mistake. First, always rule out mitochondrial. Then let's come to this. Rahul, let's go to X-linked recessive again. Okay, I'll raise this. Rahul, listen to me carefully and answer my questions. Fine? It's fine, Mohammed. Everything starts with base. Slowly it will become there. We'll come there soon. All generation not affected, right, Rahul? The first generation is not affected. So it is recessive. If it's recessive, I have to go with only one question, whether they are male or female. Here it is only men. So obviously if it's only men and this generation is not affected, so it is X-linked recessive. Clear, Rahul? Okay. Mohammed, the question being tough or not tough, no, it's very simple. If you have a base setup, right, it's very simple to create a scenario. It's very simple to correlate and solve. These questions are on the easier basis. I know it for a fact, right? You guys are in the WhatsApp group, no? Slowly and slowly, I'll push you to difficult questions. The reason why I kept the first TND to be bit on the easier side is, if I make it difficult next TND, half of you will not even attend. I've been with students for a long time. You get scared. Let's make it slow. Slowly we'll increase it. We'll make it definitely difficult for you, right? You will be able to answer easy things, fine? And also difficult things. Right answer. What's the right answer? Syed says B. Okay. Adil says C. Anyone? C. Utkarsh says A. C. Okay. Let's write this. I'll give you a simple way to write the pedigree if we are history, right? Let's always assume capital A to be normal allele, small a to be mutated allele, right? This is a general assumption always. Capital A normal, small a mutated, right? A healthy couple has a child with cystic fibrosis. Fine. Okay. Autosomal recessive. Both parents here are carriers. It's already written. Both the parents are carriers. Fine. Okay. So now both the parents are carriers means, is this right? Is this right in writing? Both the parents are carriers? Yes, na? Okay. Both the parents are carriers here. Fine. Okay. What is the risk of the next child? I think, Aman, I think this question also has a wrong answer in TND. By the way you were commenting, I'm able to understand that. Okay. Both the parents are carriers. The question is, what is the risk of their next child also having cystic fibrosis? Fine. It's a simple permutation combination. Capital A, capital A. Capital A, small a. Small a, capital A. Right. Then the last one, small a, right? Simple. Fine, Syed. Small a. Right. So it is 25%. That's all. Right. So 25% of the time, the child will be a affected person. Fine. How many is carrier? If I have to change the question, what is the percentage the next child will be a carrier? Answer is 50%. Okay. Fine. What is the chance the child will be normal? Answer will be 25%. This will be normal. This will be carrier state. Right. It's a simple one. Okay. Question में scam. Fine. Done. I'll change this question a little bit. Okay. I'll give you, I want you guys to answer. This obviously this question has to be option B will be the right answer. Fine. Let's assume one parent is completely normal, same disease. One parent completely normal. One parent is affected by cystic fibrosis. What will be the chance the kid will have cystic fibrosis? Cystic fibrosis and recessive disorder. Fine. One parent is affected. One parent is completely normal. not even a carrier, what will be the chance the kid will have cystic fibrosis? Anyone? Writing and saying is easy. Krishna says 0. Okay. 0. Superb. No. Capital A, normal. Small a, affected. The chances, all 4 of them will be carriers. 0 will be affected, right? And 100% will be carriers. Okay. Let's change the disease. Fine. One parent affected, one parent normal. Disease is Marfan syndrome. Marfan syndrome is autosomal dominant. Fine. Okay. One parent affected, one parent normal. Marfan's is autosomal dominant. What is the chance the child will have the disease? It's autosomal dominant. Upendran, read again. Autosomal dominant. One parent normal, one parent affected. Okay, why 100%? Okay, fine. It's an autosomal dominant disorder. Capital A, still normal. Capital A, small a, yes, affected. Capital A, still normal. Last one, capital A, small a, affected, right? Sorry. This third is capital A, last is capital A, small a, right? These two are affected. So what's the percentage? 50%, right? In autosomal dominant, the inheritance will go to the next unit is 50%, fine? Again, I'll change the question. Same autosomal dominant disease, both the parents are affected. What is the risk? Same autosomal dominant, both the parents are affected. So what's the risk? This is for one parent affected. Fine. If it is two parents affected, what will be the risk? It cannot reduce, right, Mohammed? Okay, Krishna says 100. Upendran says 100. Parul says 100. The problem of multiplication and not writing and saying is this. Let's see. Capital A, capital A, capital A, capital A. Can I say both the parents are affected? Right? Perfect. Great, Utkarsh. So it is capital A, capital A. The first child will be normal. Then capital A, small a, capital A, small a, small a. It is 75%. It is not 100%. Fine. See, Krishna, Upendran, Parul, Atul, Mohammed, and Syed. I'm not saying you're wrong. I'm just saying you're a bit in a hurry. 10 seconds, na? 10 seconds will change your life. Keep this rule. Any question, don't attempt in the first 10 seconds. Read, wait. Even if you know the answer, wait. The silly mistakes will reduce because patience. That's all. Then automatically everything will come. Right? Without increasing your knowledge, you can reduce silly mistakes. 10-second rule will help you a lot, right? So these are the permutation combinations for different inheritance, the risk of the future generation. Fine. Okay. Simple one. Upendran, pedigree, I hope it's easy. Percentages, you have to just draw this chart so it becomes simple. Fine. Sure, Mohammed. Hope it will help save you lots more than your 6 months. Right? It's simple as an IG, right? Type 1 hypersensitivity, need not read again. You know everything about type 1 hypersensitivity. Fine. Okay. So type 1 is classical allergic mediated hypersensitivity. Few things. There might be history in the family, right? And obviously it's IgE mediated. And the cell of type 1 hypersensitivity is eosinophils. Fine. Will you have the symptoms in the first exposure or in the second exposure? The first exposure is always a sensitization. It will never have a symptom. Only the second exposure, you'll have symptoms, right? It's always like that, right? Perfect. If the first exposure is also having the symptom, what do we call it? In other words, there is no sensitization phase. What do we call it? There's a possibility there also, right? The same type 1 hypersensitivity, when there is no sensitization, what do we call it? It's called as perfect Upendra. We call it anaphylaxis. Fine. Okay. So now I'll give you a simple way to remember what all can trigger anaphylaxis. Normal history of type 1 hypersensitivity is inhaled antigen, right? Asthma, allergic rhinitis, all I inhale, right? Can anyone tell me one example for anaphylaxis? Most of the time questions will have this example only. What's the example? Bee sting. Yes? Most of the questions of anaphylaxis you see, there'll be bee sting. Bee sting. Exposure is inhalation or parenteral? It is parenteral, right? Parenteral. Or drug. Peanut anaphylaxis is a bit unlikely, fine. Mostly, if there's a parenteral exposure, the amount of antigen delivered into the system is very high. That's why penicillin, drugs, bee sting, these are very, very common. Most of the time examples, whenever I have a parenteral route of admission of any antigen, the dose is more, the trigger can be severe. That is one reason the moment you go to internship, any antibiotic, any drug giving IV or IM needs a test dose. Test dose should be done. Without that, please don't do it, right? Because parenteral exposure always is risky, mostly won't happen. But if it happens, might be deadly, fine? So that's about simple type 1 hypersensitivity. Just to have a quick recap, this is what happens in type 1 hypersensitivity. Robin's image, allergen exposed, my peptide macrophage will present with your T cells and B cells will produce your IgE. So IgE will sit on your mast cell or a basophil, fine? So when there's a re-exposure, the antibody is already there, the antigen comes and bind. So what happens? Immediate degranulation. That releases all your histamine, leukotrienes and everything, which cause your symptoms. If it's asthma, the classical symptom is bronchospasm, wheeze, and increase in secretion, right? So that this is the simplest modality of type 1 hypersensitive response, fine? Mohammed, pathology. Asked to Siraj sir, right? I don't treat myself and I don't want to give a wrong answer for you with respect to drug. Anything with respect to pathology, please ask me. Okay. Next. Type 4 hypersensitivity is characterized by C. Sarah's gone with C. Anyone else? C. C. Okay. C. Perfect. The answer is C. There's nothing doubt in that. It's type 4 hypersensitivity. The other name is cell-mediated hypersensitivity, right? I want to just take a detour and make you understand immunology from a different perspective. See, it's always not about MCQs, no? Life is more bigger than MCQs. If you see immunology's chapter, we have few important things: hypersensitive response, autoimmune disorder, immunodeficiency disorder. You tell me which is the problematic guy. Innate immunity or acquired immunity? Innate immunity is my skin, mucosa, neutrophils, everything. Acquired immunity my B cells, T cells. Which you think is problematic? The problem or the most severe problem is always in acquired immunity. Perfect. Right? In other words, T and B cells may, there's the most of the problem. Hypersensitivity, B cell mediated and T cell mediated. Autoimmunity, B cell mediated, T cell mediated. Immunodeficiency, the worst is B cell and T cell mediated, right? So now let's leave immunodeficiency, let's take the other two. My B cell and T cell is reacting too much. Hypersensitivity. My B cell and T cell is reacting against my self antigen. Autoimmunity, right? So can I say the only problem is they are not learning properly? Yes, no, maybe. Simple. Same problem. The learning is the problem, not the practice. You guys, you practice more and more and more questions. If you don't learn, practice is a waste. learning is a problem, right? So who teaches immune cells? Because what I'm going to say is very, very important. I want you guys to do this to your kids 100%. Who teaches immune cells? Thymus. Thymus is the biggest guy who teaches the immune cells, right? Okay. Thymus will not be seen in adults, right? You and me don't have thymus. Thymus is seen only in children. So teaching stops when you become an adult. T cells and B cells don't learn after you become an adult. So the only way they can learn is when they are a child. The biggest reason for hypersensitivity and autoimmunity is a very well documented reason. It's called as an hygiene hypothesis. Because B cell and T cell learn by exposure. Okay, I saw bacteria today. I know it's a bacteria. I ate a peanut today. I know it's a peanut. Okay, I drank milk today. I know it's a milk. My body, my thymus trains them. Assume a child not having peanut till they become an adult. Possibility of hypersensitivity there? Yes. Assume a child wearing slippers inside the home, not at all playing in the playground. Possibility of autoimmunity is there? Yes. Be hygienic, not too hygienic. I always say this jokingly. Pani puri is a vaccine for autoimmunity. You eat once pani puri, no? Enough. All the organisms in panikar will be there in the body. Your body is good. Give it what it has to learn. If you miss it, it's going to learn abnormally. Washing hands is okay before eating. Using sanitizer before eating is too much. During COVID, yes. Other time, too much. Wearing slippers outside is required. Wearing slippers inside home is not required. So more and more protected you become, more and more bad your body is going to happen. Okay, so that's the reason of every hypersensitivity. And with respect to T cell mediated hypersensitivity, there's one thing which I want you to remember, because it's a previous year question and you might make a mistake, that is contact dermatitis. Contact dermatitis, what's the type of hypersensitivity? Type 1 or type 4? Type 1 or type 4? And hygiene hypothesis is not a story, that's real hypothesis in the books. It is type 4. Because generally when I say contact dermatitis, my mind thinks of allergy, right? Utkarsh, it's type 4 hypersensitivity, it's not type 1 hypersensitivity, right? Utkarsh, write a big no. It is not allergic mediated. It will trigger type 4 hypersensitive response, fine? And most of the type 4 hypersensitive response has one or two outcome. Microscopy you might have a granuloma because it's T cells, no? Or you'll have acute on chronic inflammation. Fine. Acute on chronic inflammation means you'll have both neutrophils plus lymphocytes in this patient. The reason is it is Th17 response. T cells has multiple type of response. Th17 acute on chronic inflammation. Th1 granuloma. Where if T cells becomes Th2, it causes allergy. There are three types of T cells response. Th1 produces granuloma always. Th2 is type 1 hypersensitivity and allergy. Th17 is your acute on chronic inflammation. Fine? Done. Okay. Just a spotter. This is just a simple question which you have to know. Answer? It's a simple one, no? There are two questions which keeps on coming in your SLE. One is the specific antibody and one is the sensitive antibody. The specific antibody, there are two specific antibody. One is double stranded DNA. What's the other one? Anti-Smith antibody, right? Both of them are very, very good. Both your anti-double stranded DNA as well as anti-Smith antibody. Both of them are good. What's the sensitive antibody? The sensitive antibodies is always your anti-nuclear antibody is a sensitive antibody, right? Smith as well as double stranded DNA, very specific antibody, right? ANA is more sensitive. Okay, since Upendran talked about rho, where you see anti-rho arrows as well as one more thing, anti-La. Where do you see anti-rho as well as anti-La antibody? Anyone? Anti-rho and anti-La. The other name is S or SSB. Fine. It's actually easy to remember. SS stands for Sjogren syndrome. Sjogren syndrome A antibody, they named like that. Sjogren syndrome B antibody. Yeah, lupus with respect to, I'm okay with neonatal. But in general, if I say anti-rho, anti-la, SSASB, I think of a Sjogren syndrome only. Fine. Do remember that always. Okay. Fine. Next. Okay, dry eyes rolla as a mnemonic, good one. Okay, B, C. Upendran, if 3 months is what is making you think of C, that might not be the right one. It takes years for us to go to chronic rejection, or lymphocytic infiltrate made you think of C. Can you tell Upendran so that we can take the discussion in that route, because other also might have that issue. Fine. What made you say C? Answer is acute rejection only. Fine. Okay. Answer is simple acute rejection. Okay. So the most important thing is, in general, when it's acute, okay, Upendran, we always think of neutrophils. Right? That's a general criteria. When it's acute, I always say of neutrophils, right? Neutrophil, unfortunately, is an, I'll do it, Mohammed. I'll do it for sure. Neutrophil, unfortunately, is a innate immune response. In graft rejection, the only thing which matters for me is an adaptive immune response. I don't mind about innate immune response in graft rejection, because innate immune response is very weak. I don't even care about it. Now, that way you can say it's a T cell B cell problem only. So acute also will have only lymphocytes, right? In graft rejection alone, even in acute, it'll be only lymphocytes. The only thing is, I'll have an acute humoral response, acute cellular response, because there are two types of lymphocytes, right? This is one way of looking at it. Second way of looking at it, I'm going to transplant a kidney, okay? Kidney will have nucleated cells, yes or no? Definitely, right? Which organism infects nucleated cells? Utkarsh, Upendran. Which organism infects nucleated cells? Bacteria or virus? Virus, right? Virus always infected nucleated cells only. CMV, virus, right? What is the WBC which protects against viral infection? It's always lymphocytes. Since kidney is nucleated cells, my body cannot elicit a neutrophil. Neutrophil is always extracellular. I need lymphocytes only, right? So do remember, with respect to graft rejection, it's always lymphocytes. I don't have a role in neutrophil at all in graft rejection, right? So we have 3 types of graft rejection: hyperacute, acute, and chronic. We'll have a little bit information about both, fine? Before that, what are these means? Auto, allo, iso, xeno, just to start the discussion. I'll give you examples. You tell me what type of graft it is, right? I got a graft from my identical twin. Which graft is identical twins? If it is this one, now identical twin is your isograft. Only identical twin, no one else, right? Okay, I gave my kidney to my mother. What example? Auto, allo, xeno, iso. I gave a kidney to my mom. It is allograft. Any non-identical individuals is allograft. It could be mom and son. Mom and son still is non-identical, genetically non-identical, right? Okay. Fine. Split skin graft. That's the best example for my same skin from the thigh putting to an ulcer. That's the best example for autograft, right? SSG. And also we have something called autologous blood transfusion. This also is very, very common. Fine. Autologous blood transfusion is generally done for Elective surgeries. I know I'm going to do an appendicitis 2 months down the road. Now only I take your blood, store in the blood bank. Future may I'll give you same blood, right? That's autologous blood transfusion, right? Xeno, which you don't do it, which is for animals, right? Or not just animals, other species. Anything other species, we call it xenograft. We were doing one, we have discontinued. Only thing which has been done is porcine heart valve. We were using pig's heart valve for transplant because it's more identical. We don't use it anymore because it's a biological tissue. Wear and tear will happen. Instead, we don't use pig's heart valve. Fine. Okay. Done. Now, let's look at each of the individual graft rejection. Hyperacute, na, it's a never happen event. The reason for hyperacute is there will be donor specific antibody in the host. I'll explain what do I mean by this. Okay, let's assume I am giving my kidney to my mother. Even before giving, my mom has antibodies to my body. That is donor. I am the donor here. Donor specific antibody is there in the host, the mother. How is it possible? It's very unlikely, no? I can never have antibody against you. The only possibility is if I had a previous exposure. So there are two risks. One is multiparous women. See, my mom can have antibody against me, right? Can, because I was there in her uterus when I was a child. So obviously there could have been some reaction possibility. Or patient with multiple transfusions. See, think like this. Transfusion, right? Possibility upendant that also can trigger one of the possibility, right? In transfusion, no, blood transfusion, I check A group, B group, O group or positive, negative. I don't check 𝐒𝐿, Duffy, HLA. So when a person has multiple transfusions, possibility is there, I can have antibody against your HLA. So rejects. It's a never happen event. Here, the rejection time. See, always we divide the rejection based on time, which is immediate. Immediate ka matlab, it will be on table. You suture the kidney, it will reject. It won't even perfuse. Immediately on table death is hyperacute rejection. It should never ever happen. Fine. Acute cellular, acute humoral. This is T cell mediated. This is humoral, na? B cell and antibody mediated. T cell has two types. It could be vascular type with respect to kidney. What all I'm talking is with respect to kidney, right? And tubulo-interstitial type. Where will you see antibody? In the tubules or in the vessels? It's a very simple question. No? We see antibody in the vessels. So antibody is mostly vascular type. There's one test to differentiate these two. That is C4D. Complement factor D. If C4D is positive, it is humoral rejection. C4D negative, cellular rejection. Because in both, I will see lymphocytes in microscopy. So I do a test for it, right? And this will be from weeks to months. Okay. Timeline. This is after few years. The only reason for chronic, na, let's say this is a vessel. Fine. My vessel present in my mom's body. Slowly, steadily, it will keep on reacting. Damage, damage, damage every day, every month, years. So slowly what will happen? It will become thicker. Again, more thicker. Again, gone. Lumen is gone, right? We call this, that's the pathogenesis, graft arteriosclerosis. So the moment the artery is gone, you tell me how long do you think it'll take for atherosclerosis? Months or years of development? Normal heart attack, years of problem, no? Vessel has to become small and obstructed. It will take years. It will not be in months. And graft arteriosclerosis is the reason for chronic rejection. And this is the most common type also. If it's the most common, it's the most common. Because this, na, We have drugs. I can give immunosuppressant and stop acute. Chronic, I can't stop. It will happen by default. Slowly, steadily, it will happen. It will compress and it will destroy, right? Okay. Next, Mohammed, we'll have a quick look at GVHT. Fine. GVHT is a very interesting one. It's the exact opposite of rejection. Okay. Rejection means I'm giving my kidney to my mother rejects my kidney. That is rejection. Here, I am giving my bone marrow to my mother. My bone marrow destroys my mother. That is graft versus host. Now, here what happens? The graft becomes powerful and kills the host. First question is, how is it possible? I'm just giving a graft, but the host is gone. You have to tell me, question to everyone, I want to get an answer. In this scenario, who is more powerful, graft or the host? Who should be more powerful for this to happen? Only one. Who should be more powerful? Graft should be more powerful. In other words, GVHT happens only when the graft is immunocompetent. Okay? The graft is very powerful and the host is immunocompromised. Okay? These are the time when GVHT happens. One of the very common places where GVHT happens is whenever I am transplanting immunological tissue. Kidney is not immunological, right? Is bone marrow immunological? Yes. Small intestine, Peyer's patch, immunological, right? This happens only when this happens in small intestine transplant. It's very rare, but it happens. Fine. The most common where it happens for me is bone marrow transplant. When I give bone marrow, I will suppress the immunity of the host by drugs. Only then I give, right? That's classical GVHT. In GVHT, there's a question which came before. GVHT affects fastly dividing cells. Can anyone give me one example of fast dividing cells? Because the immune cells goes and kills every fast dividing cells. One example of fast dividing cells. You know for it sure. Skin, right? So you'll have destruction of the skin. You'll have destruction of the GIT. You'll have destruction of the biliary tree. No, Krishna, normal fast dividing cells, Krishna, not the cancer ones. And in liver, you have the bile tree. Biliary epithelium. Fine. Okay. So all these are fast dividing cells in the body, right? I'm not talking cancer, in the normal body, right? So skin will be destroyed, skin will be peeled. You'll have dysentery, diarrhea, GAT gone. You'll have obstructive jaundice in the liver, right? So these are classical places where GVHT affects. Okay. Clear, Mohammed? So that's about GVHT, fine? We know about GVHT and a little bit about your transplant as well. Next. Simple question. Actually, everything is there in the question, no? 60-year-old restrictive cardiomyopathy, right? See, there's a possibility of this or this. Both can cause restrictive cardiomyopathy, right? Okay. But the only thing for me here is, I don't have any history to say this patient has chronic inflammation. That's my only concern. I don't have any history to say this patient has amyloidosis. I don't have any history to say this patient has chronic inflammation. That's why you're ruling this out. I don't have any history to say this patient is dialysis induced. But senile cardiac, yes, that's the only thing, right? Cardiac involvement, senility, that's the only thing. Any of this can involve your heart. Any amyloidosis can involve heart. It's based on the history. Since I don't have the history, I'm going for the only thing here, senility, old age, right? That's why senile cardiac amyloidosis, right? And obviously it's cardiac tissue. So obviously it is fine. Okay, Utkarsh. Okay, done. Just quick recap. I'm sure you must have seen this table multiple times. You have to tell every disease here. Okay. What disease? AL, myeloma, multiple myeloma, right? AA is what we read before, na? SAA, serum amyloid A protein. Any disease with any chronic inflammation. Could be anything. Simple TB also can cause it. Rheumatoid arthritis can cause it. TB can cause it. Inflammatory bowel disease can cause it. Any chronic inflammation can cause it, right? Rheumatoid arthritis can definitely cause. A beta 2M. Someone told A beta 2M last time. It is hemodialysis associated amyloid. Chronic hemodialysis associated amyloidosis. Fine. Okay. Fine. ATTR can be seen in senile systemic amyloidosis. Fine. And also one more type called as familial amyloidotic polyneuropathy, where there will be ATTR deposit in multiple neurons in the body. Fine. Okay. Where do you see ACAL? See, kidney is deposition. No, I am asking the disease cause. Everything can get deposited in the kidney. Where do you see ACAL? CAL stands for calcitonin. This came in last year NEET PG exam also. Mohammed, I'll tell you how questions become difficult. It is medullary carcinoma thyroid. See, everyone knows this. ACAL is deposited in medullary carcinoma thyroid. But what comes in the question is 55-year-old person presenting with a thyroid swelling. On examination, it was supposed to be a palpable mass. FNAC was done. Pink color deposit shown, positive for congruent, and some other stain positive. What's your diagnosis? This na 4-5 line, you're not able to catch the right point. Thyroid, amyloid deposit, only one diagnosis, medullary carcinoma, nothing else. Keywords. Look at the keywords, and those are more than enough. We can apply NEET PG, NST, FMG, NFD exam, same thing only. Fine. A beta is in Alzheimer's disease. Okay. This. Have you heard about AIAPP? If so, where do you see them? Where do you see AIAPP? IAPP stands for islet amyloid polypeptide. Islet means it is seen in pancreas. Okay, it's seen in diabetes in pancreas. Okay, perfect. Upendran and Utkarsh. Type 1 diabetes, type 2 diabetes. It's seen in two conditions. One is insulinoma, which is a tumor of the beta cells. There also I can see them. Type 1, type 2. You won't do it next time, moment, right? It is, obviously it is type 2 diabetes mellitus. Just think, if you think you know the answer. See, amyloid is excess deposition. Type 1 is insulin loss. There's no insulin. Who will get deposited? Nothing will get deposited. But in type 2, insulin resistance. So you'll have more and more and more insulin production. So it can get deposited. That's what happened in type 2 diabetes mellitus, right? Not in type 1 diabetes mellitus, right? And obviously you know the stain. What's the stain for amyloid? Repeated multiple times. It's your congruent. After congruent, you see in a normal light microscopy, it'll have the salmon pink color. After salmon pink color, you use a polarizer. This is the color in the polarizer. What is that? It's your apple green. In normal HNA, amyloid is a protein. It'll obviously be pink in color. Fine. Okay. Apple green birefringence is classical for amyloid. Okay. You shouldn't miss that. Done. Next. Okay. I'm having lots of answers for this question, A, B, as well as C. Okay, so it's a hallmark of malignancy, no? Malignancy cannot be hyperplasia. Hyperplasia can lead to malignancy. Not all of the option. D is metaplasia, Upendra. Fine. This also can lead to malignancy, not a hallmark of malignancy. Fine. Okay. Dysplasia, yes, partly. The only reason it's not a hallmark is low grade dysplasia, it's still reversible. It is not irreversible. It's not cancer. It's a possibility of a cancer, right? But anaplasia is the worst degree of dysplasia. This is hallmark of malignancy. If you see this term, hallmark, two things. One is anaplasia, the other is metastasis. These both are classical hallmarks of cancer. Anaplasia as well as metastasis. Rest are not. It can cause cancer, doesn't mean it's a hallmark of a cancer. These two words, wherever you see, it has to be cancer by default. Fine. Okay. Simple one. After this, let's go for a tiny break, 5-10 minutes, then let's come back and start again. PSA, most useful. I should not have a question like this, no? Simply, just for namesakes to have some happiness. Fine. Mohammed, you typed B now or before? No, it's wrong, right? It is C, right? It's prostate carcinoma, right? The only thing I want to say here is if your dad is above 45 or 50, just do once a PSA. That should it'll be normal. It's not normal. Let's take care of it because PSA is a very useful test. Will be abnormal even in BPH. But something has to be done because prostate cancer's only risk factor, predominant risk factor is age. More older man becomes, more risk of him getting a prostatic cancer by default. Fine. Okay. That's just about prostate cancer. Just few more words. I'll write the tumor marker. You tell me what cancer. Uh, Beta HCG. You keep on typing whatever cancer it is. Sure, Upendra, I'll try doing it. I'll do it for sure. Alpha fetoprotein. Then you have CA125. Few things which have been asked before. Choriocarcinoma primarily, or I can say molar pregnancy. These are two places where it's actually used. This HCC primarily and also your yolk sac tumor, non-seminomatous germ cell tumor, you can have it. Fine. CA125, where do you see? CA199, the 3 CS, no? CA153. Where is C125? Aman, ovarian is not complete. Can anyone complete ovarian? Obviously 99 is pancreatic and 15.3 is breast cancer. There's a guy on Instagram called as medical school mnemonic. That guy is mnemonic. 9 looks like pancreas and 3 looks like breast parenchyma, right? So I said that that's your breast cancer and that's your pancreatic cancer. Fine. Stupid way, but it works. You can remember that, right? What ovarian? Can anyone complete it? Adenomatous ovarian carcinoma, it is epithelial tumors of ovary. The word epithelium is very common, very important because in ovary you can have teratomas, right? Dysgerminomas, granulosa cell tumor. It's not elevated there. Like you said, exactly. I'll see them in mucinous carcinoma, mucinous adenocarcinoma, serous adenocarcinoma, clear cell carcinoma, all those. Only in epithelial tumors of ovary, it will be elevated, not in the others. Fine. That's very important for you to remember it. Okay. Perfect. Right. Let's have a tiny break. It's 5:54. I'll come back by 6 p.m. Just go have a cup of water if you want to relax for 5 minutes. Come back. Fine. Okay. See you by 6 p.m. I won't shut down this. It'll be in the same place. I'm just switching off my audio and video. That's all. Thank you guys. Hey guys, back, audible, visible. Please let me know if you're back. If so, we'll start. Okay, let's quickly go through. We have like 13, 14 questions left. Try to complete early. Okay, can you guys answer the question? Upendran, the questions are visible, right? Completely. I hope it is. Fine. Okay, what's the right answer? Mutation which are the proto-oncogenes most commonly implicated? Sure, Utkarsh. I'll wait. Ready, Utkarsh? Okay, let's start. So Aman Muhammad Aswasai said option B, KRAS. Absolutely right. KRAS is the most common proto-oncogene implicated. The most common gene overall in any human cancer has to be TP53, right? That's the most common thing. See, you go to Robbins or to any book, there'll be a huge list of genes which are written. And this can cause cancer, this can cause cancer, and everything, right? Ideally, not required to read everything, right? It's there, Syed. After completing this, we have hematology, right? Couple of more questions, then we'll start hemat. Okay. Can you guys see option D? I think it's visible for me in the screen. I'm not sure, Upendran. If others guys can see, please let me know. Okay. The genes which are required for diagnosis and prognosis, you have to know by default, and it's must because that is required for us to evaluate patients. Fine. So that's why it's required, right? Upendra, just can you tilt the phone? Maybe the YouTube screen is blocking it. Fine. Okay. So what we'll be reading is these are the list of proto-oncogenes which are must to know for diagnosis. Same way, the next question, these are the list of tumor suppressor genes which are must to know for diagnosis, not from an entrance point of view. Whatever is applied in real life will come to entrance because the person who's going to create questions for you is a practicing oncologist or a practicing surgeon or a practicing physician. They will know only what is applied in the real life. In breast cancer, there are 21 genes implicated, but the normal thing known as ERPR HER2/neu. BRCA1, BRCA2, that's all. Only the normal applicable genes will be required, and we'll quickly read them, right? So we'll go to first EGFR family. So EGFR family, we have two types, right? One is ERB-B1 or the other name is EGFR. Fine. The second is ERB-B2. See why I'm saying both the name is initially everyone used to know the other name which is HER2/neu. Last time they asked a different name. ERB-B2 is the other name for HER2/neu. Where do you see HER2/neu? HER2/neu is seen in everyone knows it's in breast cancer, right? That's not difficult at all. You're right, Syed. Lung. What type of lung cancer is important? In lung, you'll have adenocarcinoma, you'll have squamous cell carcinoma, you'll have small cell carcinoma, right? EGFR is actually the most common mutation in Asia, even in India, with respect to lung adenocarcinoma. Okay? With respect to lung adenocarcinoma, that's important, right? Perfect, Syed, right? So this is required practically. If I'm diagnosing a patient with lung adenocarcinoma, without EGFR, treatment cannot start. That's why it's important a physician knows, you have to know about it, right? ALK receptor. ALK is seen in a lymphoma called as ALCL, anaplastic large cell lymphoma. That's where it was initially discovered, fine? And also it is seen in lung adenocarcinoma. Okay, lung adenocarcinoma, we have three things: EGFR, ALK1, and KRAS also. KRAS is seen in almost every cancer. That's why it's the most common proto-oncogene involved. But where it is required, three cancers: lung adeno, must to know; colon, must to know; pancreas, must to know. There are rules that if pancreatic carcinoma is negative for KRAS, it is not pancreatic carcinoma, something else. That's how much confidence the genetic mutation has in this place. It's also seen in CNS tumors, but I'll never teach you that. Not required. These are three must to know. Fine. Where do you see ABL? I'm sure everyone knows it as BCR ABL. Actually, ABL is the oncogene, right? ABL is in classic chronic myeloid leukemia or your CML. Fine. Okay. Where do you see JAK2? JAK2 also is in a hematological condition. You see JAK2 in your polycythemia vera. Okay. It's in polycythemia vera or your polycythemia rubra vera, right? That's where you see JAK2. Fine. c-KIT is seen in GIST. It's seen in seminoma, dysgerminoma. Fine. It's also seen in mastocytosis. Mast cells neoplasm, mastocytosis, right? See, all these are proto-oncogenes. Okay. There's a common template for proto-oncogenes. That's why I have grouped them. So let's say a random question comes, name this gene, proto-oncogene or tumor suppressor gene. Or a question comes, all of the following are proto-oncogene except. So it's very difficult to remember that way, right? Okay, these are things of proto-oncogene. There's an easy statement for it. Okay. One. Can anyone tell me what's the treatment for CML? Chronic myeloid leukemia. I'm sure you guys know it. It is? Comment. It's fine. Comment. Imatinib, right? Everyone knows that. There's a treatment for JAK2. That's for polycythemia vera. We call it ruxolitinib. There are lots of monoclonal antibody. Treatment for HER2/neu, trastuzumab, right? Lots and lots of monoclonal antibody. So if there is a targeted therapy to a gene or to a mutation, it is proto-oncogene. I cannot have a targeted therapy for tumor suppressor gene. Why? Because all the oncogenic mutation, it's always gain of function mutation only. So there's more function. That's why I can put the antibody to stop the function. Every proto-oncogene is more function. That's why I can do the antibody to stop the function. So these two are template. For every proto-oncogene, this will apply. So maybe use this concept to memorize few proto-oncogenes. Okay, I have trastuzumab, HER2 is proto-oncogene. I have imatinib, BCR-ABL is proto-oncogene. I have ruxolitinib, JAK2 is proto-oncogene. Like that, we can reverse learn. Fine. Okay. The next one. Next question's answer. Okay. TP53 gene product primarily functions to which is the following. Sorry. Mohammed has gone with B. Parul B. Syed B. Syed has gone with C. Aman has gone with C. Aman, don't say I have marked option C in the answer test. If it's option C in the test, it's wrong. Okay. P53's primary work is to repair the DNA function. Fine. Okay. P53, what's the other name for P53? It's okay, Syed. What's the other name for P53? P53 also called as guardian angel of the genome. Sorry, Aman. Fine. Is the guardian angel of the genome. Fine. Policeman or the guardian angel, right? So I always think my guardian angel in my life is my mother. For most of you, it's your parents, right? So P53 is like your mother. If you remember your mother, it's very, very, very simple. It's exactly like your mother. You must have done multiple fraudulent activities in your life, right? You go into your home, your mom will ask you, looking at you, what did you do? She has that capacity. Like that, P53 can identify any mutation in the genome. Any mutation. Okay? Any mutation in the genome, it can identify. Okay? Like your mother, okay? Like your mother, she will stop you and ask you, tell me what you did. Like that, P53 will stop the cell cycle. It's your mom, no. It can stop wherever she wants. Bedroom, bathroom, or in the first entry point, right? So G1S, G2M. It can stop wherever it wants. It can stop the cell cycle. Like your mother, will question you and advise you. Do DNA repair. If everything is perfect, then cell cycle continues. Okay, cell cycle continues. Fine. Like your mother, let's assume if you're not listening to your mom, what will your mom do? Sometimes only one thing works, na? Slipper. Same thing. If I cannot correct the defect, if the defect is not correctable, P53 takes Puma or GAD45, right? Sometimes this only works. Remember Puma? BIM, BID, BAD, Puma, Noxa. Sensors of cell stress that will activate backs and back that will kill the cell. So P53 is more stricter than your mother. Do a mistake, correct, otherwise die. Right? Otherwise die, that's all. That's how strict it is. But imagine if P53 is gone, no one to check mutation. That's why it's worst gene to get mutated. Whenever P53 is gone, undoubtedly prognosis is bad. Because it's one of the worst gene to get mutated because every mutation will go unchecked. No one to check. This is the function of P53. The normal function is to repair DNA damage. That's the function of P53. And P53 is a tumor suppressor gene. I'm writing TSG for tumor suppressor gene. Fine. Okay. Upendran, TP53 is a gene. Human P53 is TP53. Okay. P53 is the protein of the gene. Okay. That's all. That's the only difference. Fine. What I have answered. Okay. TP53 is the gene and P53 is the protein. Okay. Don't get confused. It's a protein and the gene. P53 stands for 53 kilodalton protein production. That's all. Sure, Syed. I'll do it. Okay. So, see, every tumor suppressor gene, no, it's always a loss of function mutation. That's something which you have to remember. Every tumor suppressor gene, the function will be lost. Fine. Okay. How many alleles do we have in the body? How many copies of every gene we have in the body? We always have 2 copies. Na? Okay. We have 2 sets of chromosome. We have 2 copies. Imagine P53 also has 2 copies in chromosome 17. Fine. Now imagine one copy is lost. Will the other copy still function? Yes. Will the other copy still stop the mutations or suppress the tumor formation? Yes. So when will a person have cancer? 1 mutation or 2 mutation? So every tumor suppressor gene should have 2 mutations, or we call it biallelic loss. Perfect, Syed. I need to have biallelic loss to form cancer. This was given by Knudsen. Knudsen said, okay, this hypothesis, Knudsen discovered this in retinoblastoma, in RB gene. He discovered an RB gene. It's not only for RB gene. Every tumor suppressor gene needs 2 mutations. Not just RB, TP53's tumor suppressor needs 2. Right? And one more clue, almost every cancer syndrome, okay, almost every cancer syndrome will be tumor suppressor genes only. Do you guys know any syndrome? Name any syndrome. Any cancer syndrome. Cancer syndrome ka matlab like your von Hippel-Lindau syndrome. Right? That's a cancer syndrome. Like that. Every cancer syndrome is tumor suppressor. CDH1, tumor suppressor. Von Hippel-Lindau, tumor suppressor. Peutz-Jeghers, FAP, Cowden. Right? Lots of colonic polyposis syndrome. All of them are tumor suppressor. Lee-Fromney, tumor suppressor. Congenital retinoblastoma, tumor suppressor. Mohammed, paraneoplastic syndrome is a symptom. Ignore that. I'm not talking about paraneoplastic syndrome. I'm talking about cancer syndromes. Everything is tumor suppressor. Fine. Remember, exceptions are MCQ. Exception is MEN2. There is MEN2A, 2B, no? MEN2 is red proto-oncogene. Exceptions are always important, right? It's a red proto-oncogene. And one more syndrome is a That name is Beckwith-Wiedemann syndrome. Fine. Beckwith-Wiedemann syndrome is seen in your Wilms tumor, which causes Wilms tumor. That also is proto-oncogene. These are the exceptions. Rest everything is tumor suppressor gene. Need not memorize it. Peutz-Jeghers syndrome, tumor suppressor gene. And almost every cancer syndrome, link this also, is autosomal dominant inheritance. You can generalize it. Need not memorize. Lee-Frommel is autosomal dominant. FAP is autosomal dominant. Von Hippel-Lindau, neurofibromatosis is autosomal dominant. Reduce memory. These are core concepts of science. It will not change. It will always be the same. Fine? Done? Okay. Now let's look at few of the cancer syndromes. RB gene, fine. It's also called as governor of proliferation of cell cycle. Fine. Okay. You see in this retinoblastoma and one more tumor which is being increased is osteosarcoma. Look at these combinations. These combinations are very important. I have these. I suspect this cancer. P53, the syndrome's name is Lee-Frommel syndrome. If a patient has leukemia, CNS tumor, sarcoma, breast cancer, think of Lee-Frommel. This is a combination. I look for Lee-Frommel. Syed said CDH1. CDH1 codes for a protein called as 𝐒𝐿-cadherin. Can anyone tell me which tumor you will have 𝐒𝐿-cadherin loss? Two tumors. One is stomach cancer. One variant of stomach cancer called as diffuse gastric cancer. Why do I call it diffuse? 𝐒𝐿-cadherin holds cells. Lost, the cells diffuse. And perfect. One more carcinoma of the breast, which is lobular carcinoma of the breast. Fine. These two are classical Lee-Frommel syndrome. Okay. Perfect. Done. Okay. Done. VHL. Von Hippel-Lindau syndrome. Here you'll have clear cell RCC. That's one. Pheochromocytoma. That's other one. Then is cerebellar hemangioblastomas. Right? Okay. This is also classical. Metzger-Krugenberg, super RAM. The reason why it's undergoing metastasis, cells are dispersed. They can spread. They can easily spread, right? APC is the one which is seen familial adenomatous polyposis. You need minimum 100 polyps to diagnose familial adenomatous polyposis, fine? STK11, this is thing which is mutated in Peutz-Jeghers syndrome. Fine, classical Peutz-Jeghers syndrome. Can anyone tell me Peutz-Jeghers syndrome's findings apart from the polyps? Polyps will be there. Never forget Peutz-Jeghers syndrome risk of pancreatic cancer. You'll have close to 50 times risk of pancreatic cancer. Never forget it. One more finding in the lips. What is that? That's also very, very classical finding. You'll have mucocutaneous hyperpigmentation. As a very, very classical finding of Peutz-Jeghers syndrome, right? Black color in the lips, classical of Peutz-Jeghers syndrome, right? These are the combinations which I want you to look for, okay? Some important tumor suppressor gene which you have to remember, okay? Done. Okay. Next. Yes, Ram. TNM staging differs from histological grading by assessing. Yes, Mohammed. See, Mohammed, everything will come from basics only. It's about twisting and turning. See, exam is like having a gravy. Sometimes you put paneer on it, sometimes you put mushroom on it, sometimes you put chicken on it. Gravy is the same. It's just mixing and matching, that's all. TNM assesses what? TNM does not look for cellular differentiation, no? TNM primarily assesses tumor size and spread. TNM. Tumor size, nodal metastasis, and distant metastasis, right? This is primarily your tumor size. This is metastasis. nodal and distal metastasis, right? So tumor size and spread is what TNM assesses for, right? What do you think is the difference between staging and grading? There are two terms which is normally used, right? Grading of the tumor and staging of the tumor. Okay. I'm coming to you, Rupendran. Fine. Surgical staging, grading is always microscopic. I give the grade of the tumor, right? It's by pathologist. What does grading mean? Let's say normal squamous cell function is to produce keratin. If I have keratin, well differentiated. No keratin, no differentiated. That's all, right? Or poorly differentiated. Grading is nothing but how close the tumor is with normal tissue. That's all is grading. Okay. One more example. Can you tell me? Can you guys tell me whether a breast tissue will be positive for estrogen receptor, normal tissue? Yes or no? Yes, obviously. Breast parenchyma will be positive for estrogen receptor. So ERPR positive is well differentiated. That's why triple negative breast cancer is worst prognosis. So this is primarily based on microscopy, based totally on differentiation. Differentiation of the tissue, we call it well, moderately, or poor. That's all. Fine. So what is staging? Staging is not done by pathologist. It's a combination. Radiologist, surgeon, as well as pathologist, right? It's always a combination. This is the extent of spread. How more it spreads, right? It's always TNM. Tumor size can be assessed by radiology. Clinically also you can assess. Pathologically also you can assess. Node generally by pathologist because I get the biopsy specimen. Node clinically you can say it is enlarged. That's all. You can never say it is enlarged and metastatic. Could be reactive also, no? So it's a combination. That's TNM staging. Grading is microscopic. Staging is always clinical, pathological plus radiological together. Fine. Okay. Upendra, surgical staging, not grading. Grading is always microscopic. Fine. Okay. Next. Mohammed, paraneoplastic syndrome. Ram, in real life, so what they do is generally they will put CTNM for clinical staging, PTNM for pathological staging. Okay. Obviously, clinically they'll stage the tumor. Based on that, they'll give a treatment. After the specimen comes to the pathologist, we will give the accurate staging. Right? It's always CTNM, PTNM. That's how it differs. Right? Okay. Paraneoplastic syndrome is commonly mediated by hypercalcemia is mediated by secretion of PTH. That's parathyroid related peptide, right? So let's see what does PNS means. Paraneoplastic syndrome. The definition says they are symptoms or signs which are not related to anatomy or physiology of the cell. That's all. I'll explain what it exactly means. Fine. Let's say a patient has prolactinoma. Okay. Prolactin's normal function is milk secretion, right? And the symptom is galactorrhea. Is it a symptom or paraneoplastic? This is a symptom. That's all, right? It's a simple symptom. Fine. Okay. Now let's say prolactinoma is there in the pituitary, right? Is there in the pituitary, right? It can compress the optic nerve, yes or no? Sudha ma'am must have taught you about the visual field defects, right? So prolactinoma compressing optic nerve, can I say it's anatomical? Obviously it's anatomical, right? I can explain it, but I'm giving you a different scenario. Prolactinoma presenting with bone marrow failure, can I explain? Yes or no? I can't explain. That is paraneoplastic. When I can't explain, I call it paraneoplastic. As simple as that. Based on anatomy and physiology, I call it paraneoplastic, right? Few syndromes which you have to know, which has been asked before. Okay. Cushing syndrome, classically seen in small cell lung cancer. One of the classical findings. Small cell lung cancer, you also see one more syndrome, which is SAADH. I'm sure you know what is SAADH. Syndrome of inappropriate ADH secretion. That's SAADH, right? This is the most common endocrinopathy in your paraneoplastic syndrome. The most common overall is hypercalcemia. You see them in breast cancer. You see them in squamous cell carcinoma of lung, not small cell carcinoma. Fine. It's due to the PTH related peptide. Polycythemia is seen in RCC, clear cell RCC primarily, and also in cerebellar hemangioblastomas. Fine. I'm sure you must have heard about acanthosis nigricans, no? This black color in the nape of the neck and the trunk. Normally, if you see acanthosis nigricans, what will you suspect? You suspect insulin deficiency, right? That's what you generally suspect, and diabetes. Here, if it's not that, you think of gastric tumors and uterine cancers. Fine. Trossius sign is different. Trossius phenomena is different. Yeah. PCOD is also a combination of insulin resistance. PCOD, diabetes, all the metabolic syndrome, everything comes into play. Fine. Trossius phenomena is superficial thrombophlebitis. I'm having thrombus in all the veins. Superficial thrombophlebitis. Right? So when will I suspect Trossius phenomena? Just remember this. Any mucin secreting tumor. Previously, it was only pancreatic carcinoma. Fine. I'm cut to say it 1 second. Because mucin can directly activate factor 10. So if factor 10 is activated, it can cause definitely a thrombus formation, right? Okay. Syed, see, paraneoplastic syndromes, the incidence keep on changing. Cushing's is definitely much more common. But these are rare instances, right? Now, let's say I am having a tiny group of oncologists related to me. I'm getting all the incidents and I'm giving them to the authorities. My paper will say, okay, SAADH is more common. So when it's very tiny numbers, no, please don't go on incidences and they won't be asked also. It's more of clinical presentation. Cushing is definitely more common than SAADH, but please always keep with a pinch of salt. If it comes in exam, it's based on the data which is available in that paper. Fine. Next, rectal aplasia. Rectal aplasia is common in thymoma. Thymoma, you can have one more syndrome as well, paraneoplastic syndrome, which is myasthenia gravis. Both myasthenia gravis as well as rectal aplasia are immunological condition which is seen classically in patients with thymoma. Fine. Okay, these are few paraneoplastic syndrome which you have to remember. Maybe recap in the final go. Fine. Okay. Next. Okay. It's a classical metaplasia, no? It's a very classical metaplasia. Can anyone tell me what lining is this? What is red color and what is black color? What lining? Black is your... Ram has also told me what metaplasia is. Let's look at it whether what metaplasia is it. So black is your... Maybe I can call it an columnar epithelium, right? What is red color? Red color is your squamous epithelium. How do you say it's squamous? Squamous because of the layers, the layering, right? So this squamous columnar it's actually an example of columnar metaplasia like Ram said. Squamous epithelium is becoming columnar epithelium. I'll ask you two questions. One you answer, one I'll try to explain to you. Where do you see columnar metaplasia in the body? Where squamous epithelium becomes columnar epithelium with goblet cells produces mucin. What could be the etiology? It's a classical patient of columnar metaplasia. Where do you see them? You see them classically in long-term GERD in your esophagus. Perfect. Barrett's esophagus, right? Amazing. Okay. I'm sure everyone must have learnt about Barrett's esophagus in your surgery and also in pathology, right? In endoscopy, there's a classical finding of Barrett's. I'm sure you know the answer also. But I'm going to tell you why the finding. Because why ignites interest. Squamous epithelium is always stratified, right? Multiple layers. Columnar epithelium, even in the image, no? Look, it's a single layer, right? Now imagine below both the epithelium, I have blood vessels. Yes, subepithelium, every epithelium will have blood vessels. Now tell me, which epithelium's blood vessel will be easily visible? Multi-layered squamous or single-layered columnar? Always single-layered columnar, easily visible, right? So can I say columnar always looks red in color? Yes. Compared to squamous, it's always pale because of multiple layers. And this columnar epithelium is secreting what? Mucin, right? Will mucin be shiny? Yes or no? Obviously shiny, right? So whatever Utkarsh said, I need not memorize because the red velvet-like appearance is because of columnar epithelium and mucin. That's why I'm so confident even in an endoscopy without microscopy, okay, it is Barrett's esophagus. Science is always evidence-based. That's a simple evidence, no? To say it's a red velvety appearance, right? As a classical metaplasia, you're absolutely right in the answer. Fine. Okay. Answer? I wantedly give the other name here. This is nothing but your classical target cells, right? Looking like a target. Target cells, other name is codocyte. Okay. Target cells actually in your electron microscopy looks like a hat. Codo is hat. Okay. If you look, it's like a hat. That's why they call them codocytes. Fine. But microscopy base, I look from the top, it looks like a bullseye or a target. We call it target cells, right? Which condition do you see target cells? Any one condition which comes to your mind first? Target cells are classical finding seen in case of your thalassemia, right? There's a classical finding seen in thalassemia. Okay. Next, the simple question. Ram, the mechanism of target cell is nothing but membrane damage. It's a simple thing. I'm not going to discuss much about it. Reactive leukocytosis is nothing but an acute inflammation. Can anyone tell me how many of you got this wrong? If you have got this wrong, there's a problem because easy questions, no, you tend to overthink. Okay, a question cannot be this easy. Some wrong mistake is there, some twist is there. Examiners tried something, so let's overthink and write the wrong answer. Utkarsh, keep this in mind. In every exam, 1/3 of the question should be solved even before completing MBBS. Utkarsh, Mayur, Parul, am I right in saying that all three of you overthinked it and said, okay, it's a very simple question, cannot be as simple as that, something twist will be there. That's the medical student syndrome. Always thinking everything will be bad. Sometimes question will be easy, 1/3 question will be very easy. Please don't overthink. Please don't overthink. Again, without increasing your knowledge, you can improve your score. Okay, don't overthink. Next question. Okay, why not B12? Upendran has gone with B. Rest C of you have gone with C. My question is, why not B12? Answer is C. I am not denying that. Why not B12? No neurological problem. Very good. Anything else? See, because of negative finding, if the question says no neurological problem, I can write. It's not given, no? Iron deficiency, you can rule it out. My question is only between B and C. Because these two are both microcytic anemia. No problem at all. Anything apart from neurological deficit? Because it's not written there. Alcohol abuse. Good. That's a history I'm looking for. Fine. Yes, see, malonic acid not given is okay. But if it's not given, I can say it is present or absent. Both are possibilities, no? I can take a decision with whatever is given to me. That's all right. Alcohol use is given to me, right? Now, let's approach nutritional anemias. See, nutritional anemias are the most commonest in real life, but not that common when it comes to MCQ. Unfortunately, people ask more questions in hemolytic anemias, right? Now, when a nutritional anemia is given, when I say nutritional, there are three important things: iron, B12, and folate. Iron history, I look for mostly nutrition, like a poor socioeconomic status, because still now iron deficiency anemia, nutritional deficiency is the most common. Fine. Okay. Still now, I look for nutritional problem, intake related. If it's not intake related, for an MCQ, generally it's about blood loss. That's how most of the MCQs are made, right? So if it's a child, I look for the history of pica. Pica is very classical for iron deficiency anemia, eating innominate things, right? I'm sure some of you must have eaten chalk deficiency, simple thing, right? And the most common thing is worm infestation, right? In a women, the most important problem for iron deficiency is the menstrual irregularities. Menorrhagia is the most important cause of iron deficiency there, right? This is also very, very important. Elderly. Keep in mind, elderly male or female, doesn't matter, like 60, 70 years. If the patient is having iron deficiency anemia, the next step to do is, this also in real life, occult blood in stools. Fine. Okay, just give me a second. Sorry guys, come back. Occult blood in stool. If the occult blood stool is positive, you suspect colon cancer. In an elderly person, slowly and steadily, blood keeps on losing from the colonic adenocarcinoma. That's the most common cause. Fine. If it's an elderly, please look into this. Not just in MCQ, even in real life. So for IDA, I suspect these. These are the history I look for, right? So what do I look in microscopy? Microscopy, by default, I look for microcytic, hypochromic RBCs. But there's one characteristic cell which says, okay, it's an iron deficiency. That is pencil-shaped RBCs. Fine. And what do I look for in CBC? MCV, MCH, leave that. RDW is wider. Menster's index is greater than 13. Classical for IDA. For thalassemia, it will be the opposite. I can explain why, but we'll see them sometime in the Telegram session. But an easy way to remember, thalassemia. Okay? RDW less, Menster's index less than 13. Opposite is IDA. Right? Very simple way to remember, right? Okay? That's for your iron deficiency anemia. Next, if it's the other nutritional deficiency, which is megaloblastic anemia, right? Now, again, I'm going with history. Then we'll come to your investigation, right? So, megaloblastic anemia has two things: B12, folate. Okay. What is the history for B12? Apart from neurological deficit, food history. These are nutritional anemia, right? What will be the food history? No. See, Mohammed, the vegetarian, no. It's veganism. Vegetarian diet is never the cause of B12 deficiencies, vegan diet. Okay, vegan is different, vegetarian is different. Fine. Ram, I'll come to it soon. I'll complete this and go to iron profile. Fine. Vegan diet or rest everything is absorption defects. Rest everything is absorption problem. Okay. Let's say absorption defects, which is like pernicious anemia, gastrectomy done, the colonectomy done, right? Colectomy done. Folate, it is no fruits or vegetables, that especially green vegetables in diet. Okay, important. Go back to your physics, chemistry, biology, path to MBBS. Let's see you back soon. Because folate is seen in meat, folate is seen in milk, but when you heat, when you cook, folate will be destroyed. Greens, not even spinach. I can't eat spinach without cooking. I'm talking about that lettuce. You have that in burger, no? The salad without cooking. If you cook, folate is gone. So fruits and vegetables are the richest source of folate. Not there in diet, possibility of deficiency. And the worst thing is alcohol. Alcohol interferes with absorption. These are what I look for, dietary history. Then like you guys said, a neurological deficit is positive, by default B12, there's no neurological problems in folate. The SA subacute combined degenerative spinal cord, position sense problem, vibration sense problem, paresthesias, anything neurological is present, B12 not present folate. In both, you will see the same thing in microscopy. Microscopy is common for both. Classical one is the hypersegmented neutrophils. Fine. That's the most specific finding for megaloblastic anemia. And also I'll see macrovalocytes. That is classical for your megaloblastic anemia. I'll ignore whole jolly body. These two are more than enough for move with. Okay. Fine. Done. This is how you differentiate folate and this is how you look for iron deficiency, right? Since you asked for iron profile, I'll give you a simple way to remember iron profile. Okay. See, there are 4 things in iron profile: serum iron, transference saturation. Okay. We have serum ferritin and TIBC. I'll convert TIBC into affinity to iron. Okay, just for remembering that. Okay. I am not the right person. Please ask your physics teachers, chemistry teachers, they'll better guide you. Now let's look into it. See, remember like this. Let's assume you are sitting in a room. The room has 10 chairs. 2 people only come and sit. 8 chairs are vacant. The room has 10 chairs and 50 people come. The room is flooded, right? Transferrin is the room with seats for iron. Iron will come and bind in the transferrin. So if less iron come, saturation will be more or less? Less. More iron is there, getting saturated and overflowing. In other words, these two is always directly proportional. Meaning, one is more, other is also more. One is less, other is also less. Is that clear, everyone? If yes, tell yes. These two are always directly proportional. Okay? If it's clear, let's go to the next one. Ferritin. Ferritin is storage form of iron, right? I'm sure you accept that. Fine. Ferritin is storage form of iron. Now, let's take storage and affinity. You have not had dinner, no? Tummy storage is empty, right? Affinity to food is more or less? More. Even if it's a hostel food, I'll eat because I'm hungry. Let's say I've completed the dinner. I give food, like, no, done, because stores are full, right? So whenever storage is full, affinity to binding is always less. Whenever storage is empty, affinity to binding is always more. In other words, these both are always inversely proportional. Understood? When ferritin is low, TIBC becomes high. Clear? Yes, no. If this is clear, iron profile is done. I just need the concept, that's all. Let's take IDA. The most common compared with IDA is anemia of chronic disease. Is the most common compared thing with IDA. In IDA, what will happen to serum iron? That's there in the question, no? Iron deficiency anemia has to be less. If first is less, what will happen to transference saturation? Iron less? Less. What will happen to ferritin in iron deficiency anemia? That's the most sensitive test. Storage will be less. If storage is less, what will happen to TABC? Inversely proportional will be more. Clear, Ram? It's simple conceptual thing. I don't want you to remember any value. Remember the concept. One is low, other will be more. Other is low, other will be more. That's all. For anemia of chronic disease, start from here. Because the first half we read that ferritin is an acute phase reactant, right? So in any chronic inflammation, what will happen to ferritin? It will be more. Put a star mark here. I have to start from here. If ferritin is more, TIBC is less. If storage is more, free iron is less. If iron is less, saturation is less. If you want to write this, ferritin is an acute phase reactant. And in chronic inflammation, it will be more. Right? That's all. Clear? These are the only two things which keeps on confusing in iron profile. No need to memorize. Know how it is written. Automatically you'll know the rest. Fine. First and 2 is directly proportional. Next 2 is inversely proportional. That's all. Fine. Simple, Ram. Even in liver disease, what will happen to LDL, VLDL and everything? It will be lost. So in liver disease, my problem is the entire phospholipid bilayer is weak. So it becomes bigger. That's all. So it's a membrane problem, not the RBC's problem, not the RBC production problem. That's why I have macrocyte. Fine. Macrocyte is different. Megaloblast is different. Fine. Next one. Answer. This is a scenario created on a simple PYQ, which I'm sure you know, right? HMB45, right? Superb. Okay. CK is a marker for every epithelial tumors. It's a very sensitive marker. It is not a specific marker at all. It's sensitive marker. That's all. Fine. S100 is also a marker for melanoma, but it's a sensitive marker for melanoma. The question is asking specific, right? There are two specific markers for melanoma, HMB45 and melan A. Both are very, very specific marker for melanoma. Fine. Ki67 is proliferation index. It is not a marker for anything. It says the cell is dividing, that's all. If Ki67 is 10%, 10% cells are in dividing phase. The rest everything is resting. That's what it means. That's all. Fine. There are few IHC markers which you have to know. Okay. I'll come to this now. Fine. The few IHC markers which must to know. One is CK, we already know. Second is Vimentin. Vimentin is positive for all the mesenchymal tumors. Okay. Next, you have your TTF1, napsin A. Both are markers for primary lung adenocarcinoma. Only for lung, not for other things. Fine. P40, P63. These are markers for any squamous cell carcinoma throughout the body. It can be from skin, nose, larynx, your esophagus, lung, cervix, anywhere. Any squamous cell carcinoma is a perfect marker. P16 indicates HPV infection. So cervical squamous cell carcinoma will be positive for P16, right? Ram, an easy way to remember. CK7 is for upper aerodigestive tract. That's how CK7 is. Anything above this, embryologically, anything above the ligament of Treats is CK7 positive, which includes salivary gland, aerodigestive, which includes lung, upper part, little bit of breast parenchyma also, though I don't use it for breast, and upper GIT. All these are CK7 positive. Fine. P40 is best side. Okay. If you want, write this here. P40 is better. CK20 is for anything lower GIT. Again, embryologically lower GIT, which means anything below the ligament of Treats, it is positive. Fine. That's the logic behind these two. Okay. So it helps you to somehow eliminate few options and write a few things, right? Desmin has been asked before, like Ram said. Desmin is a marker for muscle tumor, okay, especially striated muscle tumor. That's why I say rhabdomyosarcoma. Okay. And one more marker is SMA. Simplest thing to remember. SMA stands for smooth muscle actin. So positive for smooth muscle origin tumor, which is leiomyoma. SMA stands for smooth muscles actin. Right? Few common things for you to remember with help of IHCs. Right? These are like the basic must to know things for you. Fine. Done. Next. Answer. It's a simple one, right? Family history of breast, ovarian cancer, undergoes genetic counseling, BRCA1, right? Let's say option 2 is, say, next option is BRCA2. What will you choose? The next is BRCA2. The option C, I am changing it to BRCA2. What will you choose? Then also, I'll choose BRCA1. Purely based on incidence. Don't change. It never change. Fine. It is BRCA1 is seen in 55% of breast cancers. BRCA2 is seen in 35% of breast cancer. Still, I'll choose BRCA1 only. I won't change. Fine. Because based on incidence. What will make me choose BRCA2 is if there's a history of male breast cancer. The incidence of male breast cancer is a little bit more common in BRCA2. I'll think of BRCA2. Fine. One more history might help me. If the breast cancers is ER positive, I'll think of BRCA2. Okay. Men and ER positivity, I'll think of BRCA2 because all the BRCA1 cancer are triple negative cancers. They are ER, PR, HER2/neu, all negative. They'll not be positive for ER at all. So these two are the one which will help me lean towards BRCA2. But by incidence, BRCA1 is much more common than BRCA2. So please always choose BRCA1, not BRCA2. Fine. Okay. P10. P10 is seen in a syndrome called as Cowden-Hamatomata syndrome. When I suspect P10 is, I have a colonic tumor and I have an endometrial tumor. Endometrium P10 is one of the most common genes is mutated, right? I suspect P10 hematomatous syndrome or the P10 loss. Fine. Okay. Next. Right, nothing new. Simple one, right? What's the answer? You guys already know the answer because it's a pretty simple question. The purpose of the question is to look for the keywords or how to approach the hemolytic anemias. We know what all to look for nutritional anemias already. We also look what all to look for hemolytic anemias, right? I'm going to write you the keywords. I want you to tell what will be the most common or most likely anemia here. I'm talking about everything about hemolytic anemias, fine? Okay. Let's say 10-year-old, recurrent, unexplained, painful episodes. Diagnosis. Just by history, what do you think of? I'll keep writing history. I want you just to answer. 35-year-old, presenting with gallstones. Fine. On examination, spleen is palpable. Diagnosis. I'll write other findings also soon. Just comment on what you think of diagnosis for one by one. Okay. 3-year-old, recurrent blood transfusion and failure to thrive. Failure to thrive का मतलब, you know that the patient is not growing properly, no? Failure to thrive. What's the diagnosis? Please comment. If it's wrong, it's completely fine. But I want you to tell what you think of, that's all. Okay. Next. 35-year-old had a history of fever. Post fever, there was hematuria. I'm talking about hemolytic anemia purely. Nothing else, no other diagnosis. What do you think of hemolytic anemia? Okay. The next, let's say 47-year-old has a history of terminal cancer. Okay. And Pedigree is seen in the body. What do you think of? Okay, again 5 history, no? Let's look at one by one. You're absolutely right for sickle cell anemia. Sickle cell anemia does not present with anemia, it presents with vaso-occlusive crisis. Please remember, the history is always due to vaso-occlusive crisis. It is never due to anemia, especially with sickle. The dactylitis, chronic non-healing ulcer, autosplenectomy, that's how the symptom will always be. Yes, when you do CBC, anemia will also be there, but this is the most common symptom, right? So microscopy, you can see sickle cell, and the best way or investigation of choice by default is HPLC. For any hemoglobinopathy, I'll go with HPLC, right? Next, this is a very classical finding. No history of anemia, which means the anemia is very mild. Elderly person, right? Perfect, Aman. Elderly person, gallstones, splenomegaly present, I'll always think of hereditary spherocytosis, right? Because here, anemia will always be mild. Why gallstones? Recurrent blood loss has pigmented gallstones. The most classical finding for hereditary spherocytosis. Obviously, there'll be family history also. Okay. Few classical findings for spherocytosis. One, elevated MCHC. No other disease has elevated MCHC, only spherocytes, right? And here, investigation of choices, EMA flow cytometry. That's investigation of choice, right? Third one, what is it? If you have a 3-year-old child not growing and repeated transfusion, thalassemia, classical of thalassemia, right? Very severe, and this patient is transfusion dependent. Any question when it's transfusion dependent, which means without transfusion, patient will not survive. That's classically thal major. And in peripheral smear, my clue for it is target cells. Target cells are diagnostic, right? And again, investigation of choices, same, HPLC is better. Okay. This now fourth history, classical history of trigger induced hemolysis, right? This is trigger induced. There's a trigger here. The trigger here is fever. Ram, I won't think of PNH for the only reason PNH will have only early morning hematuria. That's a classical finding of PNH, right? After a fever, there's hemolysis. Or after having fava beans, there's hemolysis. Right? There's a classical finding of trigger-induced hemolysis, a classical finding of G6PD deficiency. Okay? Fine. That's a very classical thing, right? If I have an early morning hematuria, that is definitely your PNH, like Ram said, fine. Next, elderly person with cancer and Pedigree. It's not a direct finding, but terminal stage cancer can always have DIC. DIC may in microscopy you'll have your cystiocytes, and my diagnosis will be fragmentation syndrome. Fine. Okay. And G6PD deficiency will also have your classical bite cells and one more structure called as an Heinz body. Okay. Done. So a few things with keywords you'll be able to solve it. Got it? Perfect. 2 or 3 images for spotters, because images are important for RBC disorders. What do you think this is? This is a simple spotter. I'm sure you know the answer. Aram, TTP will always have a neurological symptom. Renal failure, thrombocytopenia. There's a penton, no? Fever, neurological symptom, renal failure, thrombocytopenia plus histiocyte. I'll think of TTP. Right? There's a classical finding of acanthocyte. Irregular spikes, acanthocyte, right? You'll have irregular spikes. That's classical for acanthocytes, right? Also known as pulsars. You're absolutely right. Fine. Few quick images to recall. What are these? Spotters. Seen in liver disease as well as in A beta lipoproteinemia, like Syed said. That's a classical codocyte. Let's use the other name, no? Not target cells. Obviously, you see them in thal. You can see them in sickle. You can also see them in very severe case of an iron deficiency anemia. The reason for target cells or codocyte is membrane damage. Anything which causes membrane damage, possibility to have this. Fine. Okay. I'll come to it, Ram. The regular projection. Fine. The regular projection in case of RBC disorder, we call it echinocytes. Looks like a sea urchin or bursal. Fine. This is classically seen in CKD. Okay. This is due to toxin. The uremia induced toxin causes this. Fine. I'll quickly tell why it's different in both of them. Just give me a second. Fine. Okay. This is your irregular spike. Right. That's your acanthocyte. That's an irregular projection or a spur cell, classically seen in liver disease and also in your A beta lipoproteinemia, like Syed said. Fine. See, A beta lipoprotein, liver failure. In both, I have a problem in the lipid. So I have RBC which is being closed under pressure. Problem in lipid. Let's assume this part lipid is abnormal, spikes. Niche the lipid is abnormal, spikes. So wherever lipid is not getting replaced properly, it spikes. That's why irregular. In CKD, I have a toxin-mediated damage. Imagine I am putting RBC into a box of toxin. Outside, entire RBC I'll have damage. That's why it has perfect, proper, regular spikes. Because it's damaging from outside and it's damaging everywhere. Fine? Okay. Can anyone tell me what this is? And where do you see? What is this and where do you see? That's a perfect. We always go for sides, right? We call it dacrocytes, dacrocystorhinitis, right? Teardrop cells. You see them in myelofibrosis. It's a classical finding seen in myelofibrosis, fine? Okay. In myelofibrosis, we see the dacrocytes or we call it teardrop cells, fine? Okay. Perfect. Degmacytes is the other name for bite cells. I have not put bite cells here, but I'm sure you know how a bite cell looks. Fine. Okay, done. Diagnosis. What do you think is the answer? I'm sure I must have known the answer. It's a classical case of an Heinz body. How did you say Heinz body? Because the answer had Heinz body? Because there's no clue here, no? Not even a history, nothing is there. But you are able to say it's Heinz body. You're absolutely right, it's Heinz body, right? These are all RBC inclusions, fine? So there are quite a few RBC inclusions which is seen and we have to know about it. The one basic thing in RBC inclusion, like Ram said, is I need to know what stain it is. Whether it's a new methylene blue stain, that's a supravital stain, or it's a Leishman stain. If you know this enough, then I look for the number of inclusions. This is a new methylene blue stain, bluish RBC, no? This is Leishman stain. I hope you can see the difference. Leishman, new methylene blue. Leishman, new methylene blue. You should not make a mistake here. If you make a mistake here, it is gone. Fine. So if it is a new methylene blue stain and if it is multiple inclusions, multiple is multiple tiny dots. You can see, no? Multiple tiny dots. We call it, actually it looks like a golf ball. We call it golf ball inclusions and it's seen in alpha thalassemia. A classical finding of alpha thalassemia, particularly HBH disease, right? Classically seen in HBH disease. New methylene blue, multiple uniform alpha thal golf ball. Same new methylene blue, but single inclusion. That's your Heinz body, like what we saw in our question and seen in G6PD deficiency. Fine. It's a stain. The stain gives me the clue, or I should have a history, right? Here, new methylene blue, single inclusion, you have Heinz body. We have here this Leishman, no? In Leishman, RBC will be like a normal RBC, reddish color. This one, multiple, single, multiple. It's not just multiple, it's multiple and uniform. Uniform means it is throughout uniform, throughout the RBC. Now, I'll show you one more image. Look at this inclusion. This also is new methylene blue. So this also is Leishman. Multiple, but irregular. Only in one corner I see. Compare this to this. This is multiple and uniform. That's your basophilic stippling. You see basophilic stippling in multiple places where the nuclear fails. I can see them in megaloblastic anemia. I can see them in cancer chemotherapy drugs. You can see them in lead poisoning, right? Wherever I have a problem in my nucleus maturation, I will see basophilic stippling. Leishman, uniform, multiple inclusions. Same Leishman, single. Only one tiny dot per RBC. That's your Howell-Jolly bodies. Howell-Jolly bodies is seen in condition with spleen's absence. Splenectomy or asplenia. If there's no spleen, could be autosplenectomy, could be congenital, could be surgical induced. I see Howell-Jolly body, right? Mohammed, generally I don't see Howell-Jolly body in case of megaloblastic anemia. I think that's a misinterpreted question somewhere in the recall. Fine. Okay. So we don't see Howell-Jolly body in case of a megaloblastic anemia. We see only when my spleen is abnormal. Splenectomy plus megaloblastic anemia can have Howell-Jolly, but not just pure megaloblastic anemia. Very, very unlikely to have Howell-Jolly bodies. Fine. Next, Leishman, Okay, multiple and not uniform. It's not throughout. Fine. We call it Pappenheimer body. Pappenheimer body is seen in classical case of sideroblastic anemia. Fine. See, all these inclusion bodies can come in an exam, either in the form of an image or linked to one scenario based questions. Fine. It can definitely come in exam, right? If it's an image based question, what I want you to do is just look at the Leishman or Pneumothin blue first. Okay. Then look at what's happening. Single, multiple, and then go with the diagnosis, right? Perfect. Okay, the last question. I've tortured you for successfully 4+ hours. What's the answer? Upendran, you can't make it. I think it's an by mistake you have written answer A. Silly mistake. Wrong. Everyone knows it, na? KW lesion is the most specific finding seen in case of a diabetic kidney, right? Classical specific find for diabetic kidney. KW lesion is a nodular glomerulosclerosis. Fine. It's a nodular glomerulosclerosis that is classical for your diabetic kidney. Fine. Something which has to be, you have to remember, it's a spotter. If you see a glomerulus with a nodule, think of KW lesion, right? Two more things in kidney. These are hypertension induced changes. Somewhere in the initial half of discussion, I told you, if something is pink in color, I'm not exactly sure of what it is made of. What is it? I'll come to Armani-Epstein, give me time. What is it called? What is the term we give? Something is completely pink in color, like here. I'm not exactly sure what it is made of. Hyalin. So it's an hyalin involving arteriolosclerosis, right? So we call, which is classical finding of benign hypertension or benign nephrosclerosis, classical in kidney. Fine. This is looking like onion skinning, no? So the hyperplastic arteriolosclerosis or your onion skinning appearance is classically seen in which one? Not samoma. These are kidney vessel changes, Mohammed. It's classically seen in case of malignant hypertension. Yeah, samoma also microscopy wise it looks like that. It's not samoma. It's hyperplastic onion skinning of the blood vessel seen in case of malignant hypertension. Fine. Clear? Okay. Since you asked for Armani, I'll talk about Armani as well. See, Armani-Epstein lesion is nothing but clear vacuoles of glycogen deposits in PCT. Right? It's not that common. The reason is when, see, PCT's function is reabsorption, right? So when there's an uncontrolled diabetes mellitus, very untreated, then only I'll have glycosuria. Not all patients of diabetes will have glycosuria. So when I have glycosuria, PCT reabsorbs them and stores them. That is what is Armani-Epstein lesion. That's why you kind of ignore that. To have Armani-Epstein, the patient should have like 250 above continuously for 4-5 years. Possible, but rare. Right? That's why nodular glomerulosclerosis is much more specific than Armani-Epstein lesion. It's a finding in PCT, glycogen deposit in PCT. Fine. Okay. Mohammed and Syed. Fine. Done. So that's about our class. I was supposed to take a class for you on lymphoma and leukemia. Okay. Mohammed, I'll have a session on not like a TND. We'll discuss multiple times. I'm there on the WhatsApp group. Do ping me. I'll definitely talk about that for sure. And I'll talk about few sessions in Telegram also will be aligned. And before the exam, we'll definitely have a marathon where I'll quickly read. We'll quickly read again everything which is required for an exam point of view. Fine. Cell cycle. Okay, so it's G0 is always the resting phase. Fine. Okay, from G0 the point of entry is always G1, then I have S phase, then I have G2, then I have M phase. Okay, S phase is the synthesis phase where the DNA duplication occurs. Okay, you must have read in biochemistry na, the semi-quantitative division of DNA. Whatever happens to multiply, that's what happens in your S phase. Fine. Okay, then here I have a checkpoint, we call it G1S checkpoint, and I have one more checkpoint here, we call it G2M checkpoint. These are two checkpoints which are available, G1S as well as G2M, right? Which is a common checkpoint seen. Only two checkpoints are there. There's no checkpoint between S and G2 and M and M, right? Once says M, it obviously becomes two cells mitotic, right? G1 phase, we prepare the cell for division. So we make sure all the proteins, the DNA, all the energy required for cell division is being taken care of in the G1 phase, right? So now to progress from one phase to another, we need cyclins and cyclin-dependent kinases. Cyclins are cyclin A, B, and C. And cyclin-dependent kinase, you must have heard about cyclin D, CDKs. CDKs with numbers will be there, right? So those both are required for me to move from one point to the other, right? So now G1 to S phase may normally have retinoblastoma. This retinoblastoma guy will block everything from going to G1 to S phase, fine? So for me to escape retinoblastoma, I need these cyclins. So I'll have cyclin D along with two CDKs, CDK4 and CDK6. This helps me to cross G1 to S phase, right? That's the first one, fine? Then S phase may also require cyclin. Though I don't have anyone to transit, I need cyclin E here. For me to sustain here, cyclin E is required along with CDK1. When I move slowly from C to G2 phase, I need more cyclin. There's no checkpoint, but still I'll require cyclin, right? I require cyclin E here and here cyclin A along with CDK1 and 2, right? The last, for this checkpoint to escape, I need cyclin B and CDK1. The most important cyclin which you want to remember is G1 to S because that's the most important checkpoint for sure. Cyclin D, right? This sequence of cyclin was once asked D, E, A, B. Fine. So D, E, A, and B, that's a sequence of cyclin which is required for your cyclin-dependent kinase. Nothing new. General pathology is everything, right? If you know general pathology, rest everything should be automatically taken care of, right? Is that fine, Syed? You want anything in particular? Do let me know. I'll talk about it, right? See, guys, from PW, you must have got a link for a WhatsApp group. Join the group. Me and Siraj sir will be there. We're trying to engage you daily. So we know for a fact that you guys have read. The only thing is, you guys have to read daily. You need guidance. We'll be there. We'll talk with you guys daily. If you have any concerns, do ping us. We'll take care of it, right? Upendra, marathon will happen a week or two before the exam. So it's final go. What to read just to go before the exam. We'll cover all these things required, right? Krishna, I'll ask them to send again. I'll definitely send again, fine? Okay, Said, the radiology thing. The radiology thing I'll leave to Rishabh because see, mine is more theoretical knowledge in that. Rishabh knows more practical knowledge about it. Rishabh will talk about the radio resistant, radio sensitive and everything about it, fine? Okay. Thank you guys. Thank you for an amazing time and sorry for taking your time off on a Sunday. All the variables read well. I want everyone who is live here and also your friends to clear the exam. Let NMC do whatever they want. We'll make sure the percentage increases to 50% above this time. Fine? Okay. Sure, Mohammed. Fine. Thanks a lot.